Okay, we're going to go ahead and get started. Thank you for all of you that are here in person and that are on virtual as well. We had close to 300 people sign up for this, so it's really exciting for us. Dr. Grivas and I have been leading this for several years. It's always a lot of fun for us. Please give us feedback afterwards, what you liked, what you didn't, what you'd like to hear the next time. We try to kind of keep rotating different topics for those of you that keep coming back time and time again. So please, we really appreciate that kind of feedback. We have a great cast of characters speaking today, wonderful leaders in urology, medical oncology, and radiation oncology. And it's hard because we're really trying to go across the entire gamut of bladder cancer, from early stage to kind of more locally advanced to metastatic spread cancer, and really trying to have something that each one of you can hopefully take home from this talk, recognizing that some of the lectures may not be as pertinent to you, but hopefully you enjoy it. And also some sessions that are important about, exercise and nutrition that are always recurring themes people want to hear about, and talk about caregiver burden too, for those of you that are the caregivers and the supporters and the families in this room too. So I guess I didn't introduce myself. I'm Jonathan Wright, urologic oncologist here at the UW Fred Hutch. Been here now for a long time. And I'll introduce Dr. Grivas to go ahead and keep things moving. So thank you again. We're going to take questions after each talk. We also can, for the online people, they will be, Petros and I will be answering questions on the chat as well. So thank you again.
Thanks much, Jonathan. I always say, I came here about 7 years ago now. Time flies, and Jonathan is one of the reasons I came here, and he inspires me every day, and you all inspire us to do what we do, and we're very, very excited to be here with you today. You are the reason why we do what we do every day, and also why we do this event. So thank you for inspiring us, and thank you for being here, both in person and virtually. We appreciate all of you. I'm Petros Grivas. I'm a medical oncologist here, and I work together with Jonathan and a great team of amazing people. You will meet many of them today. We have a lineup of spectacular speakers here, so we're excited about that lineup. And it's a team, it's a partnership, and we want to keep this event every year, because we know with Jonathan and the team is important for the patients. And we'll do the thank you at the end, but a very quick shout out to Ritu and her team. Jonathan and me are grateful to your support and getting this together with your amazing team at Fred Hutch Cancer Center. I will introduce first Barb. Barb is a fantastic survivor, person, friend, and someone who has helped us quite a bit, along with Gail, Janine, Debbie, and many others, many other people who are Jaden, the whole organizing committee for the Bladder Cancer Walk. I don't want to forget any name because everybody contributes meaningfully. So, Barb, would you mind saying a few things about the walk? And I know you have a great table with the team outside.
Good morning.
You can use Barbara. You can use it.
Sure. Start again. Good morning. Thank you all for coming. How many of you have actually participated in the Beacon Walk before? Oh, we have lots of new people to invite. Awesome. So Beacon is a program, a company that was started by a husband and wife. Husband had bladder cancer. We can talk about that more. There's lots of information about Beacon and all the things that it does. There's programs, there's flyers and information. So what we're going to focus on today is the walk. And what the walk does is it helps raise funds to support caregivers, patients, and it funds research for new cancer treatments. So it's an amazing group of people. And we're having our walk this May, the 17th. Check-in starts at 9, opening ceremony at 10:30, and then the walk starts at 11. We have an amazing amount of food, coffee, fellowship before the walk. We're going to have lots of events, like there's going to be some goodies that you can buy that have been handmade by some of our patients. It's just a great way to meet other people, and especially somebody who's been a bladder cancer survivor. I'm thankful it's 9 years. So there's that. There's also, you can meet other caregivers, and just, even if you come for the walk and you don't see them again for a year, it's an amazing event to walk up and see somebody that's there the next year, having met them the year before. It's great camaraderie and it's just amazing. Registration is free. If you donate $100, you get a wonderful t-shirt, and they're going to be different this year because all of the programming has changed looks. We're going into our 20th year at Beacon. So we'd love to have you all come. It's very fun. It's something you don't want to miss, because once you get connected to the people that are doing this, you'll never want to not go. So May 17th, put it on your calendar, Lake Sammamish Park. Beautiful, beautiful park. Come join us.
Thanks, Barb, and thanks again to all the amazing team members of the organizing committee. We do this work for many years. Jonathan, you started this work in 2014, is that right? 11 years ago with Dr. Montgomery and the team, so it's amazing to build on that. So thanks again for considering that, and I know you have the table outside. It's wonderful. And I know, Jonathan, you also will have a team for University of National Fred Hats team, that Jonathan is our captain, so feel free to join the team or create your own team. It's all great, and it's a great community. So we are going ahead now with the actual program. It's a packed agenda. We'll ask all the speakers, including myself, to stay on time. You can check on me, it's important. And without further ado, we'll introduce the Bladder Cancer Advocacy Network team. We have Stephanie and Patricia. Very quickly, I just want to say thank you to both of them. As Barb pointed out, this is a 20th year anniversary for the Bladder Cancer Advocacy Network. It's spelled BCAN, BCAN, but actually we pronounce it as Beacon, like the beacon of hope, beacon of light. And I think it's amazing work that Stephanie and Patricia have been doing. Stephanie, you have been to Seattle. Hopefully you're online and you can hear me. You have been to Seattle but for our walk in 2019 with Jonathan and colleagues. And I know that Patricia has been working with you for a while. We'll let you take us over what BCAN is doing for the patients. Again, the patient is the reason we do this. So thank you for joining us. Stephanie is the director of the education advocacy for BCAN, and Patricia is the senior manager. So I will let you take us through. Thank you, both of you, joining us virtually.
Oh, you are most welcome. Can you hear us okay?
Yes, thank you. Thank you so much.
Excellent. Well, I definitely want to thank Dr. Grivas, Dr. Wright, Ritu, who is organizing this entire thing, and Barb, everyone. And Patricia and I are both really thrilled to be here. You want to say hi, Patricia?
I would love to. Just want to say greetings to all, and thank you to Fred Hutch Cancer Center for partnering with Beacon for this educational program. Special thank you to Dr. Grivas and Dr. Wright for their leadership in creating a space dedicated to learning and empowerment. And I just want to applaud all the patients and caregivers who are there, either virtually or in person, for equipping yourselves with the most powerful tool, which is knowledge. And so it's a pleasure for us to be here. And I know Stephanie has a really great presentation around programs and services we have to offer here at Beacon.
And if you look, our email addresses are here. Please do not hesitate to reach out to either one of us. We're happy to answer questions or find support for you and give you information. So what I'd like to do, because we're going to go really fast, we have 5 minutes. I'd love for you to take out your phones and get to your camera so that you can scan the QR codes that are going to be on some of the resources that we're going to share with you this morning. So take out your camera and be ready, and then all of those pages will be open on your files on your phone so you can refer to them at a later time. So thanks so much for listening. Let's talk a little bit about Beacon. I know Barb mentioned that we were started 20 years ago. This is our 20th anniversary, and we've really been an organization, a nonprofit patient advocacy organization that is very much focused on education and support for patients and their families, also on advocacy and raising awareness about a cancer that most patients never heard about until they get their diagnosis. And then when we're not doing that, we're also really busy on supporting research and advancing treatments. We support over $1 million in research grants every year. And that's a really exciting thing that we are able to do, in part because of the support that we get from everyone coming to the walk. So I encourage you to join us out there at the park. When you're looking for resources, one of the first places to go is Beacon's website. I like to say that we're open 24 hours a day, 7 days a week. So when you have that, oh my gosh moment, you can find an answer on our website. So if you scan this QR code with your camera, it will open up on your phone as a new web page, and you'll be able to take a look and see what's available on our website if you haven't visited already. And within our website, we also have state listings to give an idea of what's going on in your state. This is in the state of Washington. And you can see that in 2025, almost 2,000 people will be diagnosed with a new diagnosis of bladder cancer. So this is another great resource if you're interested. For those who haven't seen it already, I encourage you to scan and order your copy, a virtual digital copy or a paper copy of our newest Bladder Cancer Basics, and also our Tips for Caregivers, which have a lot of really resourceful information and advice in there that was really written for other caregivers by caregivers. So I encourage you to take a look at the new basics. I think there might be some on the walk table, but if not, definitely get your copy online. And if you're really curious and want to know more, we have an entire library of animations and video recordings, some of whom are the speakers that you're going to see today, like Dr. Grivas and Dr. Wright, living on our website. Again, that's how you reach it, at that particular QR code. Anything you want to add, Patricia? Well, before I finish?
You're doing well, Stephanie. Keep it going.
Okay. Okay, great. If you don't listen to podcasts already, I encourage you to get on board with the Beacon Bladder Cancer Matters podcast. It's hosted by a patient advocate who is extraordinary. He talks very well about research because he's very involved in clinical trial research, but he is a patient advocate for Beacon, and he is the voice of Bladder Cancer Matters. And if you're looking for support, I encourage you to visit our Survivor to Survivor page, because we are able to match you to patients who have similar gender and diagnosis and a treatment journey to help you better understand what are some of the things that you might expect when you're going through bladder cancer treatment, and also what questions might be really helpful for you to ask your healthcare team. We have a bladder cancer app. If you have an Apple phone or an Android phone, you can scan one or the other and go to the App Store and download our new app for free, which has an enormous amount of resources, including the ability to keep track of appointments and information about your diagnosis. I encourage you to take a look. And we also have partnered with Cancer Care to create a call center. It's open during regular business hours during the week. So we're really on East Coast time, and you can call and find resources in your community or speak to a social worker about how to access care in your community in the greater Washington area, or perhaps elsewhere if you're zooming in on this particular call. And then here's the direct link to sign up. If you don't sign up at the table, you can sign up right here for the 2025 Walk to End Bladder Cancer in Seattle. So we're really looking forward to a huge turnout. We get assigned who gets to go, and I'm always on the volunteer list for saying I'd love to go to Seattle. So we'll see if they send us this year. Send me, maybe they send Patricia, maybe they'll send our new CEO, Mary Margaret Diotis. And so we'll see who comes out, but we're really excited and hope that all of you will consider joining. Patricia, you have anything you want to add?
I just want to say thank you for the opportunity to participate and be here all the way from Maryland. And we are only a phone call or an email away if there's anything we can do to support you.
Well, thanks so much for the time. We really appreciate it. And I know you have so much content that is going to be really impactful. So Dr. Wright, take it away.
Thank you so much, both of you. And again, we can't say enough how much Beacon has done for us to be able to take care of our patients. We use the resources every day. Please take advantage of those. And also, they've really helped to advance the field of bladder cancer as well, too. We've received direct funding from their organization. So just been tremendous. A couple of housekeeping items. It is recorded. Virtual attendees use the chat function. Dr. Grivas and I have a computer to try to answer them as they come along. And in person, you can see questions during after each session. We will walk around microphones, and we'll try to maybe we'll repeat the question just so that we can make sure those that are online can also hear too. And again, afterwards, please give us the feedback, really important. So with that, we'll move on to more of the content. We're going to start with early stage bladder cancer. Many of you have faced this. We face this every day too, the frustration of the shortage of BCG, which is one of our mainstays in treatment for bladder cancer. And so I want to ask Dr. Claire de la Calle to come up. She's a urologic oncologist, joined us recently. It's just been a phenomenal addition to our team, and I appreciate you being here today. Thanks.
All right. Good morning, everyone. Thank you so much for having me today. It's an honor to get to speak to you all about bladder cancer. So before I start, I have no disclosures relevant to this talk. So since this is the first talk of the morning, I figured maybe we should start with some basic bladder cancer facts, starting with bladder cancer statistics. So there are about 84,000 new diagnoses per year in the US, as we just discussed. It is a cancer that is more common in men compared to women. In fact, in men, it is in the top 5 of new cancer diagnoses every year. But the majority of the diagnoses are non-muscle invasive, meaning the tumor does not invade into the muscle of the bladder. So what exactly do I mean by that? Well, usually when we are suspecting a bladder cancer, there's a small tumor in the bladder, and we basically go in the bladder with a little camera and literally core out the tumor with a little electrocautery device, as you can see here. And then in the image on the right, you can see the transverse view of the bladder wall. And that coring out of the tumor allows the pathologist to see what grade the cancer is and what stage it is. So what do I mean by grade? So first, regarding grade, that means when you look under the microscope, how aggressive do the cancer cells look? Do they look like they're multiplying very fast and they look aggressive? That would be a high grade. Or do they look more slow growing? And that would be a low grade cancer. And then the stage is how deeply the tumor is invading into the wall of the bladder. So on the right hand, you have the more invasive tumors. These are going, do I have a pointer? No, I don't. Okay, on the right hand, you can see the tumors that are more deeply invading into the bladder wall, into the muscle, or even the fat around the bladder, or sometimes even going into other organs. But for the purpose of this talk, we're focusing on the superficial cancers. So we call them non-muscle invasive bladder cancers because they're not invading into the muscle. And these can be low grade or high grade, and they can be stage A or stage 1. Stage 1 means that the tumor is just barely starting to invade into the wall of the bladder, but not quite yet into the muscle. So once we know the stage and the grade, then we can give a risk stratification to the non-muscle invasive bladder cancer, either low risk, intermediate risk, and high risk. And so this is the risk stratification of the American Urological Association. The low risk tumors essentially are the small, low grade tumors. The intermediate risk ones are the ones that are larger low grades, or if there are multiple low grade tumors in a single bladder, or the small high grade tumors. And then the high risk non-muscle invasive bladder cancers is everyone else. So the large high grade tumors, the high grade stage 1. So those are the ones that are starting to invade into the bladder wall, but not quite into the muscle. And all the bladder cancer subtypes that are known to be very aggressive. So then once we know the risk stratification, we follow this seemingly complex treatment algorithm, which I'll over the talk take you all through. And you can see that we have on the left hand the low risk, the intermediate risk, and then the high risk patients. So because the main focus of this talk is BCG, I want to highlight that for the intermediate risk here, you see that BCG is an option, which is given in an induction course over 6 weeks, followed by 1 year of maintenance. And then for high risk, BCG is basically the standard of care with an induction course followed by 3 years of maintenance. So what is BCG? BCG is actually an immunotherapy drug. It is a live attenuated strain of a mycobacterium that is injected into the bladder through a catheter. And because it is a live microorganism, it basically makes the bladder think that there's an infection going on in the bladder. And so it's going to trigger this complex inflammatory and immune response that you can see here in this figure that ultimately leads to an anti-cancer immune response. So why do we use BCG? Well, because it works quite well. Bladder cancer has a high chance of coming back after being resected, and it also has a chance of progressing, meaning it could invade more deeply into the wall of the bladder. Specifically, high-risk non-muscle invasive bladder cancer patients have up to a 70% chance of the cancer coming back, and anywhere between 10 to 45% chance of the cancer progressing. Well, when you give BCG, fortunately, it reduces the risk of recurrence by up to 50%, especially if you give it with a long maintenance course. So you can see in the figure here on the right, the patients that got maintenance had less recurrences of their bladder cancer compared to those that had no maintenance. And then BCG also reduces the risk of progression by up to 60%. So as Dr. Wright was saying, there is a BCG shortage. This means in the US. This means that we don't have enough BCG, unfortunately, to give to all of our bladder cancer patients. So why is there a shortage? Well, the reasons, there are multiple reasons. One of them is that BCG is actually very hard to make. Remember, it's a live mycobacteria. So that means that it's very difficult to manufacture, package, and transport. The production process is really slow because it is a very slow growing bacteria. And so it takes up to 3 months just to make a batch. Merck is basically the only maker and supplier of BCG in the United States. The strain that Merck makes is the BCG Tice strain. There are other strains that are used around the world, but they're not currently approved in the United States for use. And making matters worse, it's a generic therapy and overall profit margin is low for pharma companies. And so that does not lead to a lot of incentive to make more BCG. So when will the shortage end? Well, I'm not really sure when it's going to end. I can tell you that Merck has mentioned that they're at full capacity in terms of their production. They are building a new manufacturing facility that hopefully will be complete by the end of this year or maybe next year. Once complete, it is expected to triple the manufacturing capacity of Merck. I'll get into this a little bit later, but there might be some new strains approved in the United States in the near future. And then there are some new drugs that we will talk to you all about a little bit later that might be approved in the very near horizon that would be alternatives for patients instead of BCG and therefore reduce the demand of BCG. But we're not there yet. So what can we do in the meantime during this BCG shortage? What can we offer our patients? So the first option is very simple. The patient can choose to travel to another facility that has BCG. And I have many patients that have done that. Another option is to dose reduce the BCG. There are multiple ways to do that, but one of the common ways is to literally take 1 vial of BCG that's meant for 1 patient and split it in half or in thirds. So 3 patients come to clinic at the same time, and we share the love. We split the dose for everyone so that more people can get BCG. You can enroll your patients into a clinical trial where they would get something else, for example, and so that would reduce the demand of BCG. It is really important to know who should get surveillance only and not get BCG to not overuse it. Also important to know who should get their bladders removed instead of trying BCG. That also reduces the demand of BCG. And then we have chemotherapy and new drugs in the near horizon that will hopefully reduce, like I was saying earlier, the demand of BCG. So going back to our treatment algorithm, a little bit more about surveillance. So for the low-risk patients, surveillance is definitely the best way to go. So we should never give BCG to these low-risk patients. That means that we're just monitoring the cancer to make sure it's not coming back. But there are actually some intermediate-risk patients that are great candidates for surveillance as well. These can be patients that tend to recurrently have small volume, low-grade tumors, patients that maybe are too old or frail to repeatedly go to the operating room for more resections. Sometimes we even monitor small volume tumors. It's called active surveillance. So there are intermediate risk patients that are great candidates to just be on surveillance and not get BCG. And then on the other end of the spectrum, radical cystectomy, which is bladder removal. There are some high-risk patients that are at the very highest end of the high-risk spectrum that definitely should be offered in a radical cystectomy instead of trying BCG first, because the risk of progression is so high. And these can be patients with very large stage 1 tumors or with some bladder cancer subtypes that are known to be very aggressive. So what about dose reduction? So I mentioned early splitting the dose. In these 3 figures down here, you can see that patients that got a third of a BCG dose versus a full dose had same time to recurrence, progression, and same cancer-specific survival than the patients that got a full dose. It's a retrospective study, but certainly encouraging. Now, there are other things that have been proposed to reduce the dose of BCG that we use. So we could only give induction to patients, or only do maintenance for 1 year instead of 3, or only give 5 out of the 6 doses of induction, or 2 out of the 3 doses of maintenance. My personal opinion is that out of all these methods, the favored approach is the split dosing, because research has shown that frequency and duration is more important than dose in terms of BCG, meaning you want the body to be frequently exposed to it for a prolonged amount of time to get a good response. So what about clinical trials? So there's a SWOG 1602 clinical trial that randomized patients to either getting the BCG Tice strain, this is the strain that Merck makes, versus the Tokyo strain of BCG. And then there was a third group that got intradermal injection of BCG. So basically a BCG vaccine using the Tokyo strain, followed by injection of the BCG into the bladder to see if getting the vaccine first results into a more robust immune response to the BCG. So we were a site that accrued patients for this trial, and accrual has completed, and we're hoping to get the results of this trial in the next year. And so hopefully this would lead to the approval of a new strain of BCG in the United States. Now, what about chemotherapy? Gemcitabine and docetaxel are 2 chemotherapy drugs that can be injected into the bladder, just like BCG. And in this study that I'm showing you here, patients that received the chemotherapy in the light blue curve up top had less recurrences of their high-grade cancers than the BCG group in the darker green curve underneath. Now, very important to stress that this is a retrospective study, so certainly has some bias, but it's certainly reassuring that maybe the chemotherapy will do just as well as the BCG in a prospective study. And that's exactly what we're doing right now. We're enrolling patients into this trial called the Bridge trial, where we're randomly assigning patients to either get the chemotherapy or the BCG, and we'll follow these patients over time. That's what I mean by prospective, meaning you follow them to see what happens in the future and see if they have less recurrences or progression of their bladder cancer. So this is a study going on in the entire country right now, and UW is a site, and we are currently enrolling. And this is a way for us to reduce the amount of BCG we use, since half of the patients are getting chemotherapy instead. Now, there are other types of chemotherapy that can be given in the bladder, and I've listed several regimens that we can give in the bladder here. Now, I just wanted to mention, in the complex algorithm for the low risk versus intermediate risk versus high risk bladder cancer treatment that I showed earlier, for the intermediate risk patients, in addition to BCG, there was the option of giving chemotherapy. Now, because of the shortage, the American Urological Association BCAN, SUO, and other large societies put out this joint statement in 2019 saying that because we have a shortage right now, we should try at all costs to not give BCG to intermediate risk patients. So we should really favor chemotherapy in these patients. And then in that statement, they also said that if you don't have any BCG to give, so you have nothing, then you can give chemotherapy regardless of the risk category, so even if they're high risk. And then one little thing about, just a small comment about novel drugs, as this is the topic of the next lecture, and I don't want to steal Dr. Wilcox Vandenberg's thunder, there are some new drugs that are currently being developed for patients that have never gotten BCG. And one of them is this one. It's the TAR 200. It's this little device that looks like a pretzel that you can see here in the lower left corner. It has gemcitabine in it, which again is a chemotherapy, and it slowly diffuses the chemotherapy into the bladder because the device is put in the bladder. So the patient is constantly exposed to this chemotherapy. And patients currently are being randomized to getting this device versus BCG versus the device plus another immunotherapy drug. The study is currently enrolling. And so this is only one of the several examples that we will have from the next talk of new drugs that we might have in the near future for our bladder cancer patients. So in conclusion, although the shortage has definitely put a strain on both of our patients and our providers, it's good to know that we have options during this BCG shortage. Patients can travel, we can do split dosing, we can enroll in clinical trials, we can watch the bladder cancer, we can do radical cystectomies, we can give chemotherapy, or we, in the near future, can give novel drugs. And I think it's really exciting to know that the future is bright. We have many great alternatives that are coming very soon, and I think it's really going to help improve the care that we deliver to our bladder cancer patients. So with that, I'd like to thank you all and happy to take any questions.
Time for one question. Anybody?
Muscle invasive cancer, and now it's gone, theoretically gone,
Mm-hmm.
and you develop another cancer.
Wonderful question. Yeah. Yes. That's a very advanced question. I love it. Yeah. So sometimes when you, the question is, can you give BCG after treatment for muscle invasive bladder cancer? And the answer is yes. So sometimes for muscle invasive bladder cancer, we give radiation along with chemotherapy. And we will talk about that later on today when we transition to the more advanced bladder cancer talks. And sometimes the bladder cancer can come back, but is superficial, no longer muscle invasive. And yes, we can give BCG in that setting. Mm-hmm. Thank you.
Well, Dr. Calle nicely set up Dr. Rand Wilcox Vandenberg, who we were also excited to recruit to join us as well, too, another colleague of mine in urological oncology. So, Rand, thank you.
Good morning. Good morning, everyone. I'm Rand Wilcox Vandenberg. As Dr. Wright was saying, I'm one of the newest recruits to the University of Washington Fred Hutchinson Cancer Center. I am going to be speaking today on, as what Dr. De La Calle alluded to, new approved drugs and what's on the horizon. New approved being FDA approved. So I also have no disclosures, except some of these names are quite complicated, and I apologize if I botch them. So we'll start with a little outline of my talk. I'm going to talk a little bit about where we are now, building off of what Dr. De La Calle was just speaking about, talking about what the problem is, what's next, or what's new, and then what's next. So where we are now, looking at those AUA risk groups that Dr. De La Calle was talking about, and again, going from left to right, are you able to see the marker? Nope. We have our low risk going up to high risk, and this really correlates to progression. How high of risk is there that you're going to go from low risk, become intermediate risk become high risk become muscle invasive. And you see along the bottom, it works pretty nicely. These then get broken down into our first line treatments, as Dr. De La Calle went over, surveillance for those low risk group, BCG plus 1 year of maintenance or intravesical chemotherapy for the intermediate risk group, moving on to the high risk group with longer courses of BCG. And then in those very high risk patients, the one she was referring to really that kind of moved to cystectomy a little bit more quickly, they're over there on the right. But so the problem, which she also alluded to, is that BCG works really well. It generally, at any time, patients respond about 70 to 80% of the time. And then those that don't respond can get reinduced, and then some of those will respond. But as she also is pointing out, there are shortages, and not everyone has access to it. And while the gold standard in that point would be removing the bladder, performing the radical cystectomy, which has, 10-year recurrence-free survival, about 75 to 90%. So it is a very good option for cancer control. It comes with a lot of life changes, a lot of quality of life changes, and complications afterwards. So a lot of people have come together and said, what can we do? And for about 20 years in this space, there really wasn't any advancement. And you'll see how a lot of these studies that I'll talk about are set up. We made it a little bit easier by having them all single arm, but that will get to complications later in looking at all of them. But ultimately, a bunch of these really smart scientists said, let's see what we can do. And they decided to come up with immunotherapy ways of going in and modulating the immune response to fight the cancer, coming up with viral gene therapies where a virus will be used that can't cause any other illness, but can, for instance, put a gene into the bladder cancer cells, and then targeted molecular agents, which is kind of similar, but just the molecule itself. And then also looking at novel delivery mechanisms. So some gels that dissolve over a long period of time, and that little pretzel thing that Dr. De La Calle was talking about, which has a sustained delivery device. But let's first start with these newly approved drugs. The first is nadofaragene furadenovec. First name that's really hard to say. This is a genetically altered cold virus that can't replicate, but delivers an interferon gene that's incorporated into the cellular DNA of the cancer cells and expresses large amounts of interferon. This molecule then blocks new blood vessels, activates the immune system, and blocks cancer cell proliferation. And it was approved for BCG unresponsive CIS, with or without papillary component. So CIS is that flat version of non-muscle invasive bladder cancer, and papillary component is that TA or T1 that Dr. De La Calle was speaking of. But BCG unresponsive means, as it sounds, that you got BCG and it didn't work. This one's given once every 3 months for a year. And when we look at, especially this is approved now for CIS, the complete response at 3 months was 55% with an average duration of 9.7 months. And then, about only 5% progressed to TU in that T2 disease, so muscle invasive disease at that time, and leading to about 29% getting cystectomy within 12 months. It's a little bit better for papillary only, but it's not yet approved for that. Then next is nogapendican. I won't say the rest of it, but this is an antibody that's instilled into the bladder that enhances the immune response and is interleukin-15 superagonist. So N803, which I'm going to refer to it as, acts as an activation and proliferation factor for natural killer T cells, effector T cells, and memory T cells. This is one that is given with BCG, and it follows the BCG schedule. So, once weekly for 6 weeks for induction, and then with the maintenance phase every 3 and then 6 months afterwards. And we found that at 3 months, 55% had a complete response. As you notice, it's very similar to the other drug that we just spoke about. And then the duration of response in those that did respond was about 26.6 months, so coming up to 3 years. The responders that needed cystectomy was about 11.8% at 2 years, and those that didn't respond, about 36.8 got a cystectomy by 2 years. Next is, as Dr. De La Calle was referring to, is repurposing gemcitabine and docetaxel, which commonly are given intravenously, but we're giving them into the bladder. And this is really given now for BCG unresponsive CIS or BCG unresponsive papillary. It's once again, once a week for 6 weeks, and the maintenance is once monthly for 2 years. And when we look, and this is like the problem with these data is, again, they're retrospective. So we're looking back at what happened and not tracking people through time. At 2 years, 50% had recurred if they had CIS, or 42% of papillary. 7%, again, not that high of a number, had progressed in stage, and only about 4% had passed away due to the bladder cancer. Actually, with that progression, one of the things I want to point out is with all these numbers being kind of low, it shows us that we have time to try, generally another intravesical therapy after BCG failure. So it's not necessarily everyone has to get a cystectomy. You'll talk with your physician about, what might be right, but oftentimes there is this chance. And so looking at what's around the corner. So first is this mitomycin gel. So mitomycin we've traditionally used, but a lot of these intravesical therapies that we give, we put them in, they last for a couple hours, you pee them out. Mitomycin gel, this is kind of similar to what we do in upper tract urothelial carcinoma. It's a gel that goes in liquid, turns into a solid, and lasts for 4 to 6 hours, just giving more exposure of the medication to the cancer. And this is really for low-grade intermediate risk right now, that TA designation. It's given once weekly for 6 weeks. And at 3 months, the complete response rate was 65%. And of those that responded, about 5% recurred at 6 months, and then 39% by 12 months. We have ongoing studies right now for this, the Envision trial, which is a phase 3 study, and it's pretty much around the same numbers. Then we have the other impronounceable name, cretostimogene grenadenorepvec. I won't even go with it. This is the first of new medications coming down the pipeline, which has been put to the designation of the FDA for fast track of approval. It's an oncolytic adenovirus, which means that it finds cancer cells and infects them, leading to cancer cell death and an immune response that also augments that. And this is another one that's been geared towards those with BCG unresponsive CIS, with or without a papillary component. It's given once weekly for 6 weeks, and then the maintenance phase is once weekly for every 3 weeks, and then every 3 months for a year, and then 6 months for a year. And complete response at any time was 76% for this medication. And then we don't actually have the long-term data to know what it is at 12 months yet. And then here is that TAR-200, the novel delivery system. It looks like a little pretzel. It goes in, it was given breakthrough designation in 2024 by the FDA. And as you can see, it's a small device that's placed into the bladder with a cystoscope, and it slowly releases low levels of gemcitabine. So instead of that 1 to 2 hours, you're now getting a week. It's again given to those with BCG unresponsive CIS, with or without a papillary component. And it's once every 3 weeks for 6 months, then every 12 weeks for up to 2 years. The data for this one are very immature, and they've really just been from abstracts, but complete response was 82.8% at any time, with a continued response of 74.6% at 12 months. And so now here's the hard part, comparing all of these. There's a lot of different ones. They all have very similar complete response rates, but there is something that's really important when we look at this, and that's the cost. Some of these are incredibly expensive. Nogapendican plus BCG is nearly $500,000 a year. Gemdosi, on the other hand, is about $3,000 for the first year. Nadofaragin, $250,000. And let's compare these to other ones that we have. Radical cystectomy, about $40,000. BCG, it's $200-ish a dose, so about $2,500. And then pembrolizumab, another one that's been FDA approved, but it wasn't as novel. That's also incredibly expensive, $377,000 for the first year. So bladder cancer, if you didn't know, is actually the most expensive cancer that we treat in the United States, just given all of the continued exposures, the surgeries that we do. And if we're already spending a couple $2 billion a year, we have to ask ourselves, how are we going to incorporate these medications? So there are a lot of studies that are going on. We actually have a couple going on here at the University of Washington, Fred Hutch. But the idea is that we'll be able to, hopefully find something that's cheaper, but find something that's really going to fill this space. And putting it all together, here's the current therapeutic landscape and investigational approach to non-muscle invasive bladder cancer. And we're trying to focus on this multifaceted approach, whether it be through immune activation, the BCG, the N803, immunotherapy, pembrolizumab, things that really harness the immune system of the patients, chemotherapy, like mitomycin, gemcitabine, docetaxel, or these novel delivery methods, putting in that little pretzel, or this reverse thermal gel, this mitomycin gel. So really the take-home messages from this is we have some new medications for BCG unresponsive non-muscle invasive bladder cancer. We don't yet know which one is better, but there are some hopes that we have some really good options. There are some new medications on the way, and I put hopefully, because the reality is, as you've seen, these are very, very expensive, and unfortunately, there have been a lot of cuts to NIH funding, and just the FDA approval process might have some difficulties in the next couple of years. But importantly, it's seemingly safe to try some of them before we move on to cystectomy. So I'll take any questions.
One question.
Could you say a little more about the GemDoc option? That seems more accessible, and how that compares in terms of patient experience and also to the mitomycin gel?
Comparing Gemdosi to the mitomycin gel, we don't have the mitomycin gel for bladder yet, right? Yeah. So the Gemdosi, it's actually a little bit longer process because you go in, you actually get one of the medications, we leave that in for a little bit, and then, we empty the bladder, then we add in the next one. So it's a lot longer day. So a general kind of, you look at all these intravesical treatments, a lot of them are very well tolerated. A lot of them, the effect comes from either the BCG, so a lot of those, the ones that were given with BCG, but like irritative voiding symptoms, it's pretty well tolerated. If you look at them, like a lot of the adverse effects are like the higher grade ones, it's like less than 10%. They're very well tolerated.
Thanks so much. Really appreciate it. It is exciting time for us to have all these new options for us. And like Dr. Wilcox Vandenberg showed here at the UW Fred Hutch, we have a trial open in each space, the BCG unresponsive, the BCG naive, and the and their intermediate risk as well. All of them trying to do what this next talk is about, is preserving the bladder. So myself and our first two speakers are urologists. We remove bladders, but one of the reasons we started our bladder cancer multi-specialty clinic a decade ago was to have more patients hear about the option of bladder preservation. So I'd like to invite Omar Mian to come up. It was very exciting. Again, another recent recruit that we brought that came over to the Fred Hutch, and he both is a radiation oncologist and also has a very vibrant research lab here at the Hutch too. So thank you for talking today.
Thanks so much. Excuse me. Thanks so much, Jonathan, Petros, for organizing BCAN, and of course all of you for being here. This is really wonderful to have this opportunity to talk here. I'm going to switch gears slightly. We've been hearing about non-muscle invasive primarily this morning, a little bit about overall bladder cancer staging. So in that stage grouping that Dr. Calle showed so nicely in the beginning, as you move from bladder cancer that's in the very superficial lining of the bladder, a big step that sort of elevates the risk category and gets us thinking about more, call it aggressive interventions, is that spread of the cancer, of that invasion of the cancer into the bladder wall, into the muscle wall of the bladder primarily, something that you can, generally see under the microscope. And when that happens, rather than the medicines that you think about that you put in the bladder, the intravesicular treatments, we now start to talk about systemic therapies, surgery, radiation, and treating more aggressively. And the main reason for that big jump in sort of treatment intensity is this risk of metastatic spread, which we want to obviously avoid. We want to catch this while it remains local. And so with this in mind, I want to talk to you about one type of treatment for patients who have this muscle invasive bladder cancer, if they're eligible. And so this title that you're looking at here kind of gets at that point. I'm really going to focus for part of the talk here on who is the right patient, because it's not the approach you might take for everyone. So I'm going to zoom out here a little bit with this first slide, and I just want to kind of give you this history of the trajectory of cancer medicine and contemporary care for a variety of different types of cancer. When we think about organ preservation in cancer, this is something that for many decades now has been the trend in cancer medicine more globally. Just think about the breast cancer patient who maybe, I don't know, 20, 30 years ago would have almost certainly had a radical mastectomy, a big surgery. And these days that's done relatively infrequently, because just removal of the tumor from the breast, a lumpectomy, followed by a systemic therapy or endocrine therapy targeting something like estrogen, the estrogen receptor, and radiation that comes in and kind of think about it like sweeping any residual cancer cells that may be there. That combination, a limited surgery, systemic therapy, and radiation, this tri-modal approach, is what we do now almost entirely for localized breast cancer. And the same thing is true in limb-sparing surgeries for sarcomas, voice box preservation, and head and neck cancers and cancers of the larynx, cervical cancer, anal rectal cancer, and bladder cancer. This idea that we can combine a limited surgery to diagnose the disease, to remove the visible component of the disease, and follow that with systemic therapies, okay? And the idea here is that you're prioritizing both clearance of the cancer, but also the quality of life of that patient. And it's not really putting one in front of the other. There's many clinical trials now that have shown that cure rates are equivalent when you take this sort of multimodality approach. But patients do quite a bit better because of this focus on quality of life and organ preservation. So where are we then with bladder cancer? Again, I want to sort of focus on what my component in all of this. I'm a radiation oncologist, and I think about the that sort of leg of the stool that's radiation. And when most patients hear about, oh, you're going to maybe have radiation as part of your care, they're thinking something like this, right? So it's, that they're envisioning this picture from the James Bond movie. And I say that to be a little bit humorous, but to be honest with you, I think probably a lot of doctors are picturing this exact same thing, when they think about radiation. And so I want to demystify this just a little bit. This is a modern linear accelerator. It's a device that produces high energy X-rays. These X-rays are very similar to the type of X-ray you might get if you get a chest X-ray or if you're X-raying a bone, in terms of, being X-rays. Physically, they're the same thing. The main differences are it's a little bit higher energy. Okay, so this delivery of radiation is calibrated to kill the cancer cells. And the second big difference is that you can shape the radiation. Okay, and that's what I don't have a pointer here, but on the right side of this image, you see the machine can move around. And then what you're looking at here is if you're able to look right up into that radiation delivery area, these are called multi-leaf collimators. You don't have to remember that, of course, but the whole idea here is you can shape the beam dynamically as it moves around. And this development here, again, I'll show you that as the beam moves around, you can shape it. In the end, you wind up with radiation that's really shaped pretty precisely to the target that you're trying to treat. This is the biggest technical development in modern radiation, is the ability to kind of deliver the radiation in a more conformal way. And actually this picture now is getting a bit old. It used to be your so-called IMRT, where you would have multiple beams from all around. These days, we use arcs, and the beam is dynamically changing shape. And as you might imagine, this development and innovation has been largely driven by our ability to use computers to design and refine radiation delivery techniques. And and the technologic advancements of being able to deliver this more precisely. And so with this capability, we have to ask the question, who might be the right patient who could benefit from a multimodal approach? And I'll describe that approach in a couple of slides, but I want to just get back to this idea of, who might be eligible for an organ preserving kind of approach. And so we generally think of selective bladder preservation as an approach that we might use in patients who have a smaller tumor, generally less than about 6 centimeters. It's muscle invasive, so we don't really do this for non-muscle invasive. And the main reason for that is it tends to be into the lining of the bladder. It's a little bit more diffuse. And also from our studies, when we have used it, the recurrence risk in the bladder is a little bit higher. And someone asked a wonderful question, if you do this in the setting of a muscle invasive cancer, even many years later, it's possible another cancer can develop in the bladder. If that cancer is non-muscle invasive, you still have the ability to use treatments for non-muscle invasive cancer. And so, I guess that's one of the things about organ preservation. That organ remains behind and it remains at risk of another cancer. So it's very critical that in patients who successfully go through a treatment where their bladder is preserved, that they're watched very carefully, because they have options to treat this if it comes back, whether it's non-muscle invasive or invasive. So getting back to this, muscle invasive bladder cancer is the category we're looking at. Smaller tumors, single tumors. I say this because you want kind of like in the picture here, where on the wall of the bladder you see this kind of lighter area. That's the tumor. It's in one spot. This is about a 5-centimeter tumor in the bladder. It's not in multiple places in bladder. This multifocal kind of disease where you start to worry now that maybe I can treat one or the other, but the risk of recurrence might be higher. So unifocal tumors, no bilateral urinary obstruction. I mean, it's not. There's no blockage of the ureters coming down from the kidneys on both sides, and this is related to this next point, which is good bladder function. If there's blockage of urine, or for another reason the cancer has injured the bladder to the degree that it's not working well, that patient, may not be well served by a treatment that keeps that bladder there. The whole end goal of this is that their quality of life on the other side of the treatment, once you've gotten rid of the cancer, is good. And so if you're preserving an organ that doesn't work, obviously that it's going to be a quality of life problem for that patient. So good bladder function is a critical criteria for patients in thinking about this decision around organ preservation. This should be localized disease, no spread to the lymph nodes or elsewhere. In patients who've had radiation to the pelvis before, so think of a prostate cancer patient maybe many years ago had radiation and might have a recurrence, or rectal cancer, or a gynecologic malignancy. Radiation is used for all of these, and if that's been done in the past, then a second course of radiation is very difficult to deliver because of this sort of cumulative limit of radiation a patient can get. And I said reliable follow-up care. This is important. We need to do repeat cystoscopies as frequently as every 3 months in the first years after this. And so really have to be able to watch closely. Okay, so how does this work? This Tri-Modal therapy approach. So this starts with a transurethral resection of the bladder tumor that's been described very nicely this morning. So removal of all the visible disease in the bladder. And you might ask, well, if you're taking all the disease out, why do you need to do anything else? And this is the problem with muscle invasive bladder cancer. It tends to be kind of rooted into the wall of the bladder. You can take and scrape out as much as you can. In many instances, you might say the majority of those patients are going to have a recurrence in that area because it's very difficult to get that microscopic disease in the wall. So you need more treatment at that point, and that's where the systemic therapy, so a radiosensitizing chemotherapy and radiation to the wall of the bladder. So I have all of those in pictures here. And what you're looking at on the lower right-hand side here is what a radiation dose plan might look like. And in this particular case, if you remember that area that was resected from the slide here, this is, you've gone in and Jonathan, Claire, others would go in and scrape out this tumor, and then this is followed with radiation and chemotherapy that's given with the radiation. The two work synergistically together, and the dose can be kind of focused on that area where the tumor was, but you're also going to give some dose to the remaining wall of the bladder. Okay, so what is the data for this? There's lots of comparisons of radiation to radiation alone to chemotherapy. There is unfortunately no comparisons, no successfully run randomized trials comparing surgery and radiation. And that's not for lack of trying. We have tried. Those trials tend not to accrue for a very understandable reason, which is that patients and their doctors are very reluctant to let a computer decide between two treatments as different as, surgery and radiation. And so we're left with these retrospective studies where you say, okay, I'm going to go back and I'll look at the last 500 patients who were treated at Fred Hutch Cancer Center. 250 got surgery, 250 got radiation or something like that. How do they do? And those retrospective studies are very difficult because of imbalances between the groups. You can't measure for are the groups equally, do they have the equal number of other comorbidities, or are the age is the same, or the stage is the same, right? And so there's challenges with that, but that's what we have. And so there's quite a few of these now, retrospective studies, and probably the best one was published about a couple of years ago. This is large enough because 722 patients, 2-to-1, two patients got, they retrospectively took about 440 patients who had surgery, 280 patients who had radiation, and they tried to, using statistical techniques, they matched these patients. So age for age, stage for stage, comorbidities. This person also had, I'll make it up, congestive heart failure. So we'll match that in the other group. And this propensity matching allows you, hopefully, to get closer to sort of apples and apples rather than apples and oranges. And in these studies, whenever they have been done, they tend to show the same thing, which is that for the appropriate selected patients that had the criteria I described before, that surgery and radiation have equivalent outcomes with respect to cancer control. And really the graph that shows that is over here, where the surgery and radiation overlap very nicely. All right, so radiation, to summarize here a little bit, non-invasive outpatient procedure. This is daily treatment for a period of 4 to 6 weeks, so it takes, a bit of time to deliver. Each treatment takes maybe 15 minutes. You don't feel the radiation, but side effects build up. You're going to irritate that bladder. Patients are going to really notice over the course of treatment and in the months that follow. There's other normal tissues around the bladder. Even though we can shape that radiation, the bowel is there. And so there are side effects from this treatment, including things like bowel side effects and irritation of the bladder. It's given always with, when we can, with a low dose of radiosensitizing chemotherapy. And then I'm not talking about this today, but radiation has a role in treatment of cancer that is even spread to treat the symptoms of disease. All right, so selective bladder preservation is my last slide, is an option for some patients with muscle invasive bladder cancer with the goal of sparing the native bladder. Technologic advancements have allowed us to improve our ability to target and limit dose to normal tissues. There's a ton of research in this area, combining new agents, as you've already heard about very nicely. There's a ton of things in the pipeline. Medicines that work in more advanced disease are being moved earlier, being combined with radiation, being combined with other forms of treatment like a limited surgery. And, I'm very excited about the future where we're going to be able to, I hope, cure more cancers and leave patients with a much better quality of life. And finally, multidisciplinary care is important. This is really a decision that has to be made by your care team in terms of the appropriateness of which type of treatment you can get. And so that discussion happens all the time in our group in terms of what's the right thing for any individual. All right, that's it for me. Thank you so much for your attention. I don't know if there's time for a question, Jonathan.
Fantastic. Let's do an applause first. So we actually have a virtual question. I want to make sure the virtual attendees also participate. And I think the question is, any role for proton radiation? Any role for proton therapy? Omar, you want to give a very quick context of what proton?
Sure, yeah. That's a terrific question, quite a technical one. So I talked about X-ray radiation. There's also, and we have it here at the Hutch, there's also protons, which is a charged particle therapy. The idea really, just to put it in a nutshell, is that the proton radiation may be even more targeted, maybe able to more precisely deliver the dose. There's no exit dose with radiation because of the sort of physics of how the energy is deposited. And so you can bring in the dose and just basically stop it in the tumor. We do use this for a variety of things. The best data is in small tumors, pediatric tumors, tumors of the eye, but it's used in diseases like prostate cancer. To now, there's not really been great data showing superiority of proton therapy for pelvic malignancies in terms of side effects or disease control. I love the question because in theory, just the radiobiology of protons, just how it works may in some cases be better. I think this is an area for investigation. But right now, here, again, with the capability to deliver proton therapy, we are not doing proton therapy for bladder cancer because there really is no reason to think it's any better.
Thanks, Omar. Great talk, and we'll be here so people can ask you questions later in this morning. Thank you so much. So another applause. Yes. Fantastic. Thanks, Omar. And it's my great pleasure and honor to introduce a dear colleague and friend, Dr. Rajitha Sunkara. Dr. Sunkara joined us from Boston in November 2023. And it's amazing to have her join the team. She has done a great work already and keeps doing it, taking care of patients, helping us with other roles in the cancer center. And she will talk to us about neoadjuvant and adjuvant therapy in muscle-invasive bladder cancer. Dr. Sunkara.
Thank you so much, Dr. Grivas. It's my honor to be here. I'm really humbled and honored to be presenting to such an inspirational audience. I'm sure all of you were either directly or indirectly touched with this diagnosis. So my topic here is neoadjuvant and adjuvant therapy. And my colleagues, Dr. Delakaya and Dr. Wilcox, Vanden, Berg. I think it's fitting topic for you, Rand, because your name is as hard as the drugs that you presented. Dr. Mian has done an excellent job in touching the topic of muscle-invasive bladder cancer and creating a base for me to develop my talk on. So, sorry. I will present this topic from the lens of a patient asking the questions to their doctor in the clinic. So when you hear the word of the cancer, the first thing that comes is, how are these cancer cells different? Where did I get this cancer from? So the cancer cells are not alien. They are our own cells, but might have attained some special abilities. And what are those special abilities? To name a few, which are important for you to understand the rest of the topic. The first one is resistant to death. Are they immortal? Maybe. They're very hard to kill. And the second one is they avoid the immune system. The immune system plays a major role in protecting our body, not only from the external factors, but also from any internal malfunctioning cells. These cancer cells learn how to evade the immune system and hide in our body and grow. And the third one, heterogeneous. Heterogeneity is not something that you hear often from your doctor's office, but it is one of the most important factors in helping us decide the treatment. What does heterogeneity mean? Not all cancer cells are the same in your body. So the cancer cells, if you have 1 million cancer cells in your body, maybe some percentage of them behave the same way and some behave differently. And the fourth and the most important is the metastasis. The word metastasis means it's the tissue evasion. They have developed the tendency to move out of the site of their origin. The cancer cells, so the bladder cells, they're supposed to stay in the bladder. But when the bladder cells transform to cancer cells, they learn to leave the bladder and go to other organs of the body. So now the next question will be, can you get rid of these cancer cells from my body? Yes and no. Yes, for a fortunate few, where the cancer is confined to the site of origin and no metastasis is seen, but no if the cancer has spread to other organs of the body, which are liver, lung, bone, or any other lymph nodes. And I will concentrate on explaining more as to yes for some. And I said for some here, despite saying that we can probably cure the cancer or get rid of the cancer if it is confined to the site of origin, because the metastasis, in the previous slide, I did not go there, but the metastasis can be microscopic and macroscopic. Macroscopic is what we can see with our eye in the scans. Microscopic is these cells will be hiding somewhere. They're so small in number that we might not be able to identify them on the scans. So some of these patients where we think the cancer is confined to the bladder could be having the micrometastasis, and those are the patients that it might be hard to completely get rid of the cancer. So the next question is how? How can you get rid of this cancer? Because of how smart these cancer cells are, if they're defying the death, they're smart, right? So my one small brain is not enough. So I need the help of my specialist. So we always advise the multidisciplinary approach in the multidisciplinary clinic, which we have, where different specialists will meet you on the same day, and your case will be discussed among the different specialists, the radiation oncologists, the surgeons, the medical oncologists, the pathologists, the radiologists, and will be decided, your treatment will be decided based on your own the comorbidities, what is best for you, along with you taking your preferences into account. So these are the multidisciplinary approaches, the tri-modality approach, which Dr. Mian has already described. I'll concentrate on neoadjuvant and adjuvant therapy. So what are the pros? What is this neoadjuvant and adjuvant therapy? What are the pros and cons of neoadjuvant and adjuvant therapy? So I highlighted the pros in yellow and outlined the cons in red. So let's first go to the neoadjuvant chemotherapy and its effect on the surgery. So the surgeon or the surgery, it helps us in shrinking the cancer and makes the surgery easy. The surgeon will be happy. They will be able to take out the cancer easily, and we all will be happy, right? Sometimes the side effects from the chemotherapy can delay the surgery. I haven't seen this happen, in any of my patients, but most importantly, the surgery was made easier by giving the chemotherapy before the surgery. And whatever is the pros and cons of the neoadjuvant, are the opposite for the adjuvant therapy. So when we don't give the treatment before the surgery, if the tumor is large enough, the surgeon might have a hard time taking out the cancer completely. And there might be cells left around in your body. But you might be able to tolerate the surgery better, because you're not going through any of the side effects or recovering from the side effects of the chemotherapy. So what is its effect on the cancer? Remember I talked about the micrometastasis, the cancer cells that we can't see on the scans. We can attack those cancer cells early by giving the chemotherapy, which not only kills the cancer in the bladder, but also kills the cancer everywhere in the body. And also we can personalize the approach of what to do after the surgery. As I outlined above, these cancer cells, they're very hard to kill. So, sometimes, we might be able to get a good response with the chemotherapy, but there might be some cancer cells which are very defiant and stay back and survive. So when we take out the bladder, when we see those cells, we can decide what to do next after the surgery, so that we can personalize the approach for you. And, the downside of neoadjuvant chemotherapy is if there are any very hard to kill or immortal cells in your bladder, even when we give the chemotherapy, they might not be killed, and they might continue to grow, and they might move out of the bladder, and they might spread to the other organs. So what about the adjuvant chemotherapy? It's the same thing. It's, as I said, the pros and cons of neoadjuvant are the opposite for adjuvant. So if you don't give the chemotherapy, if you have any cancer cells, microscopic cancer cells hovering around in your body, they can grow and they can get bigger, and they can become macrometastasis. That means then they will be visible in the scans, and your cancer stage might become incurable. And we cannot personalize the approach because we are sending you straight for the surgery. We don't know how this cancer behaves, and we have to go with one size fits all after the surgery. But the good thing about doing the surgery without giving the chemotherapy is if there are any highly resistant cells in the bladder, we'll be able to remove those resistant cells before leaving the bladder. And now, what does this chemotherapy do? Most of you might have heard about us talking about multiple drugs. the chemotherapy drugs are chemicals which attack the cancer cells from different sides. Each drug works differently. And because of how hard and resilient these cancer cells are, it's hard to develop resistance for them when we use multiple drugs rather than using a single drug. Also, we will be able to balance the side effects of these drugs without compromising the efficacy. It's easier to tolerate the lower doses of multiple drugs rather than one big dose of one single drug. And what is immunotherapy? So you often hear in the commercials as well about the immunotherapy for bladder cancer. Does it have a role here? Yes, it does have a role here. What the immunotherapy does, it prevents the cancer from avoiding the immune system. Remember I told you, like, one of the features of the cancer cells is they avoid the immune system and hide from the immune system in the body. So this immunotherapy prevents the cancer from avoiding the immune system and also makes the immune system attack the cancer. It can be given alone or in combination with chemotherapy, which I'll talk about it later. And these are the examples of the drugs, immunotherapy drugs, the pembrolizumab, nivolumab, and durvalumab. So what are the chemotherapy regimens or the chemoimmunotherapy regimens that we use in the neoadjuvant setting? The first and foremost is the dose-dense MVAC. It's a 4-drug combination. It's given once every 2 weeks for 4 to 6 times. And the second one is cisplatin and gemcitabine. The 2-drug combination is given over 4 cycles. Each cycle is 21 days, and both drugs are given on the first day, and one drug with the gemcitabine is given on the 8th day. And the third one, which is the new kid in the block, is chemoimmunotherapy combination. We do not have the FDA approval yet, so insurance might not pay for this. We are eagerly waiting for the FDA approval. This was recently presented, this Niagara trial looking at this combination was recently presented earlier this month at one of our GU oncology meetings. And the other thing, I also want you to look to the right. Not everybody can get this chemotherapy. These chemotherapy drugs are toxic, they're chemicals. So we want patients to be able to tolerate these drugs. We don't want to kill the patients by giving these drugs. So they should have good kidney function, they should have good liver function, their heart should be good, they should not have any heart failure. And one of the side effects of all these drugs is they affect the nerves and damage the nerves. So we also don't want any of our patients to have bad neuropathy because it can make much worse. These drugs can make it much worse. And hearing is also more important because these drugs can damage the hearing. So we do not want to give these drugs for patients who already have a very bad hearing. So this is a Niagara study design where the chemoimmunotherapy combination was compared with the chemotherapy combination. I also want to point out here, this study actually used the combined approach of neoadjuvant and adjuvant therapy. So the people who are randomized to this chemoimmunotherapy arm, they end up receiving immunotherapy after the surgery, regardless of what the surgical outcomes are. We'll talk about what the outcomes are later. So who gets the adjuvant therapy? So we talked about neoadjuvant therapy. If everyone, we give the chemotherapy before the surgery, so does adjuvant therapy has any role? That is the treatment after surgery. If we see a lot of cancer in the bladder specimen, despite you getting the neoadjuvant therapy, those are the patients we recommend the adjuvant therapy. Or if you haven't received the neoadjuvant therapy, and we do strongly advise people from getting the adjuvant therapy. So who are these people who doesn't need any adjuvant therapy after the neoadjuvant therapy? Those who had complete pathological response. That means if we give the chemotherapy for you and we send you for surgery and we take out the bladder and we don't have any cancer in the bladder that we can see, those are the patients we do not advise any treatment after the surgery and we continue to monitor them. But if we see any cancer and a lot of cancer, then we do advise some more treatment after the surgery. So this is one of the complete pathological response, the reason why we don't advise adjuvant therapy for patients who has complete response at this time of the surgery, because this is the National Cancer Database data where the survival is looked at based upon how the people responded to the neoadjuvant chemotherapy. The patients, as you can see, the curve higher, the one in the red, those are the patients who had complete pathological response. More people are alive at 6 years compared to the patients who did not get the, who did not have the complete pathological response. And that's the reason why we want to, give more treatment after the surgery. So what are the adjuvant chemotherapy drugs? This can be divided into 2 segments. And those who did not receive any treatment before the surgery, we use the same drugs that we use in the neoadjuvant setting. But for those patients who had received treatment before the surgery, but did not have a good response, we use an immunotherapy drug called nivolumab. This nivolumab often can be used also in patients instead of chemotherapy, who did not get any treatment before the surgery based on this Checkmate 274 trial that was done in both settings. So are there any measures to evaluate the benefit of neoadjuvant and adjuvant chemotherapy? Pathological complete response, as I said earlier. So if the patients have complete response in the bladder, those are the patients who live longer and down the road. And how many patients do we see this complete pathological response? Around 32 to 42% of the patients. But and it doesn't matter what regimen we use. Maybe there might be a variation by a few points, but both of the chemotherapy regimens that I have shown earlier give us this a complete pathological response in around 32 to 42% of the patients, depending on which trial you look at. Again, this complete pathological response, we cannot assess if you don't give the chemotherapy before the surgery, and we only give the chemotherapy after the surgery. So the survival, how many patients will be alive at 5 years with this treatment, the neoadjuvant or adjuvant? The numbers are almost the same, but there are no head-to-head comparisons in the sense people did not compare. There are no trials comparing whether neoadjuvant chemotherapy is better compared to the adjuvant chemotherapy. Based on the adjuvant chemotherapy trials that were done, the survival at 5 years is 56%, and the neoadjuvant chemotherapy trials across the board showed around 56 to 62%. And the side effects are the same because, as I told you earlier, we use the same regimens in the neoadjuvant and adjuvant setting. So that's why the side effects from either approaches is the same. And sometimes it might be harder for you to tolerate the adjuvant chemotherapy if you have a prolonged postoperative recovery from the surgery. And this is the Checkmate trial. Earlier in the slide, I said about using the nivolumab, even in patients who have not received the chemotherapy in the adjuvant setting. This trial looked at the patients with prior neoadjuvant therapy versus patients without prior neoadjuvant therapy. It showed the benefit in both of these groups. So that's why if after the surgery, if the patients did not get any neoadjuvant chemotherapy and they went on to receive the surgery, we still, if there doesn't have a good tolerance, not fit enough for us to give the chemotherapy, we choose to give the immunotherapy with nivolumab. And for patients who did not have a good response to the neoadjuvant chemotherapy, we do give nivolumab in the adjuvant setting based on this trial. So are we over-treating patients by giving more treatment after the surgery? Yes and no. This is a slide that was presented recently at ASCO. As you can see in the orange, these are the patients who are cured from the neoadjuvant therapy, regardless of the response in the bladder. That means these 32% of the patients most likely does not need any treatment, even when they did not have the complete pathological response. And the numbers in the blue, the 68% of the patients, they most likely, the cancer will come back And when we give nivolumab in those patients, we were able to save only 15%, but 53% of the patients, the cancer, still came back. So how do we know, who is this 15% in green is? We have some signals, but we are not there yet. One of the markers that we can look at on the cancer cells, which is called PDL1, programmed cell death ligand 1. If the programmed cell death ligand 1, it's a protein that is expressed on the top of the cancer cells. If that expression is more than 1%, those are the patients who benefited the most with this adjuvant therapy. And the other marker is the circulating tumor DNA. We look at the blood and we measure the tumor DNA in the blood. And if we find the tumor DNA, those are the patients who actually benefited also from immunotherapy, but not in this trial, but from a different trial, looking at a different immunotherapy drug, which is the atezolizumab. However, this is not universal. So patients who have more than 1% of PD-L1 expression can also not do better with the nivolumab. We need a much more better markers and much more research in this area. And these are the ongoing phase 3 perioperative adjuvant trials, looking at the chemotherapy and immunotherapy combinations, and also some of the newer agents, which Dr. Grivas and Dr. Nadal will talk about later, the targeted chemotherapy along with the immunotherapy. However, I will leave it to Dr. Grivas to explain this more. So, sometimes we also tell our patients, that we cannot give any chemotherapy, that we strongly advise the surgery. And who are these patients who have, kidney, liver, or heart damage, but are in a state to tolerate the surgery? Again, the hearing loss, the neuropathy, and also variant histology bladder cancer. The bladder cancer, the bread and butter variety, is called urothelial cancer. In some of the patients, this cancer morphs into a different variety, which is micropapillary. Examples include micropapillary, sarcomatoid, plasmacytoid, or adenocarcinoma. And in these situations, unfortunately, it's a very rare happening, but we also do not have the data. So that's why we recommend surgery alone in these patients. So this is the old neoadjuvant chemotherapy followed by surgery, no complete response. We recommend adjuvant nivolumab, PAT-CR, we recommend monitoring. And if people did not receive neoadjuvant therapy, we recommend adjuvant therapy, chemotherapy, or adjuvant nivolumab, or monitoring. And what's new, another option, it doesn't replace the earlier slide, but it's another option that you have based on the Niagara trial. So this is the summary. Cancer cells are your own cells with special abilities. Multidisciplinary approach is always advised. Neoadjuvant chemotherapy is preferred. Adjuvant therapy for those who did not receive neoadjuvant therapy, and also for those who did not respond to the neoadjuvant therapy. And patients ineligible for chemoimmunotherapy or variant histology, surgery alone is what we advise. Thanks so much.
Number one, you covered amazingly well the topic, and also you helped Dr. Nadal and me. You set the stage for us to do, to continue that. My suggestion is, just in the interest of time, Dr. Sunkara is here. Please come find here to ask questions. We can do a brief break, and let's try to, be back and start, within 10 minutes or so. So we'll try to stay on time. Maybe 10:35 will be probably the ideal. So 5 minutes or so we can try to stay on time as soon as possible. Thank you. Dr. Nadal joined us in November of this, like almost 3 months ago. She came from the National Cancer Institute, and she's joining the team, focusing her research in bladder cancer. And she's going to talk us about metastatic bladder cancer and what therapy options we have. And then I will follow her lead and talk about some clinical trials. Dr. Nadal?
Good morning, everyone, and thank you very much for having me. Yes, good. So I'm going to see if I find my slides. I don't know. They're somewhere, that's for sure.
So she can make it happen.
So thank you very much for being here today and having me. So I'm going to talk about, let's see if I have more advanced disease, those patients that the disease has already spread or they are locally advanced and they are not candidate for more radical definitive therapies like surgery or curative radiation therapy. Now is better? Okay, sorry about that. And I will start with first-line therapy, saying that, okay, here we go, that platinum-based chemotherapy has been for 3 decades our best treatment option for metastatic bladder cancer patients, with cisplatin containing chemotherapies being the most common, the most active regimen for such population. However, 50% of metastatic patients have significant comorbidities, which make them ineligible to receive cisplatin. So until now, we have always used this criteria called platinum eligibility with the goal of identifying those patients who can receive our best treatment option, cisplatin. And this criteria is based on these clinical factors. If you meet one, if the patient had one of these clinical factors, it was deemed to be cisplatin ineligible, and they were treated with a cousin of cisplatin that is called carboplatin. Unfortunately, carboplatin is less effective than cisplatin. All these agents are toxic. And in this, there has been, because carboplatin is much less effective, there has been a lot of interest on developing therapies in this space, and that led to the evaluation of immune checkpoint inhibitors. Immune checkpoint inhibitors as a single agent, they were not proved to be more efficacious than carboplatin-based chemotherapy, and the FDA restricted the use of these immunotherapy compounds to patients that were platinum ineligible. The oncology community came with this a new group of patients that they were defined by these clinical criteria that they were not eligible for either carboplatin and cisplatin. And this is the way we end up with this classification based on platinum compounds eligibility, and this has been incorporated until now in our treatment algorithms, and it has driven many of the treatment recommendations and has helped us to organize clinical trials. And we will see this when we talk about clinical trials. To set up a little bit the stage of what we were accomplishing with cisplatin-based chemotherapy, this was a phase 3 trial from the 2000s, comparing one of the most common regimens used two of the most common regimens used for metastatic disease, gemcitabine, cisplatin, and also MBAC that is composed by 4 different chemotherapy agents. The outcomes were very, very similar in terms of efficacy, comparable responses. The median overall survival, the best that we could achieve with these cisplatin-based chemotherapies, was a median overall survival of 15 months. In terms of toxicity, gemcitabine cisplatin was less toxic and was probably established as one of the preferred treatment options for patients that were cisplatin eligible. And you will see that this is the control arm of many of the next generation clinical trials in the frontline space, and also has been studied in combination of other drugs. We have also the carboplatin version of this regimen, and it's carboplatin gemcitabine. That's kind of easy. But I think it has make a big help to make progress in metastatic bladder cancer has been the molecular testing, the capability that we have to sequence tumors and to understand what actionable targets these tumors have. For example, two very important ones, and your oncologist will talk to you about that, is FGFR3 and two alterations, I forgot the two, and HER2 overexpression. So these are very important because they predict response to some targeted therapies that we will talk in later slides. Then the discovery of immunotherapy, immune checkpoint inhibitors that they disrupt negative signals between the immune system and the cancer cell and encourage the immune system to fight cancer. There are many examples, only listed some of them that are being presented in this presentation. And then the antibody drug conjugates. These are a new form to deliver very potent cytotoxic agents to the tumor, very targeted delivery to the tumor. The antibody portion, it recognizes proteins that are expressed in the surface of the cancer cells and carry the chemotherapy to the cancer cell or to the more immediate surroundings. So these chemotherapy agents are much less toxic for the body. There is less exposure of normal tissues to these cytotoxic agents. There are multiple of them. These three are the ones that I have selected for these presentations because they are relevant to bladder cancer. And there has been multiple strategies to improve cisplatin or carboplatin-based chemotherapy. There are many clinical trials. I'm going to focus on the three that has led to changes in practice. One of the strategies to improve first-line therapy has been, trying to get rid of platinum compounds and trying to develop platinum-free regimens, combining different forms of immunotherapy targeting different checkpoint molecules, and also the development of regimens with antibody drug conjugates and immunotherapy. The other strategy has been the addition of immune checkpoint inhibitors to chemotherapy, sometimes followed by a maintenance phase with immunotherapy, and finally, the strategy of switching therapies, starting with one form of therapy and then switching to a monotherapy type of therapy. And this is the concept, this switch maintenance concept was tested in the Javelin Bladder 100 study. They were enrolled patients that were receiving both cisplatin and carboplatin, so all the patients, regardless of platinum eligibility, that achieve a complete response, partial response, or a stable disease. And after a treatment-free interval of 4 to 10 weeks, they were switched to a standard of care, that is to monitor these patients for clinical symptoms and also with scans along with best supportive care, or this course of immunotherapy with avelumab, a form of an immune checkpoint inhibitor, until progressive disease. So instead of waiting until the patients develop progression, they were just switched without waiting to that progression in an attempt to consolidate these responses. The primary endpoint was overall survival, and it was met that criteria. Patients who switched to avelumab treatment, they live longer, and their disease was controlled for longer time. It did not was deleterious to their quality of life. Another approach that it has been tested, but this has been only successful in cisplatin eligible patients, so only in that patient population, has been the combination of gemcitabine and cisplatin with immunotherapy, followed without this free treatment period, just you stop the chemotherapy and continue with the nivolumab component and only up to 20 months. That this is different than the Javelin trial, that it was until disease progression, was compared to a standard of care, cisplatin gemcitabine, up to 6 cycles and then monitoring. primary endpoint was overall survival, and that primary endpoint was also achieved along with progression-free survival and a very, very important overall response rate of 58% of the patients responding to the combination therapy, with 20% of them accomplishing a complete response. So all the tumor was gone in the CT scans, in the evaluation of the CT scans. And obviously, this was also approved for frontline therapy for metastatic cisplatin-eligible patients. And finally, I think this is the most impressive, of the three, a non-platinum-based strategy with EV Pembro versus standard of care chemotherapy. In this trial, also they, both platinum eligible and platinum and cisplatin ineligible patients were allowed, and patients with very, very poor kidney function were treated. Patients with 30 milliliters mini, that's low kidney function, were treated. And also the patients that didn't have very good performance status, that were very sick because of their tumor, were randomized to the EV Pembro, only 2 years of pembrolizumab as in the prior therapy. This is not the concept of switching maintenance therapy. And EV was given until disease progression or intolerance compared to standard of care. Co-primary endpoints, progression-free survival and overall survival, and both endpoints were accomplished, doubling the time of median overall survival and median progression survival. It has been the regimen that has shown the higher overall response rate. 70% of the patients accomplish a response, and 30% of the patients will accomplish a complete response. So this trial was presented by Dr. Powells at the ESMO, I think 2023, and the audience gave him a big ovation. Because it was very, very, emotion. It was a lot of emotion that a non-platinum-based chemotherapy was, producing these outstanding results. And obviously, it has been also approved for the treatment of first-line therapy. Then moving to the second line and beyond, I'm going to be a little bit fast because, you give in the second line and afterwards what you have not given in the first-line setting. And most of this drug has been proven superior to giving our standard second-line therapy, our taxanes and binfluin in Europe. So all these agents that are approved for second-line therapy and third-line therapy, except a couple of them, have been proven to be superior to standard chemotherapy. First, I'm going to talk about immune checkpoint inhibitors in monotherapy. It's less and less frequent to have patients that get to the second-line therapy and they have not already received immune checkpoint inhibitors, because you have seen Dr. Sunkara explaining that we are incorporating immune checkpoint inhibitors to even the neoadjuvant space. But if you receive one of these patients, maybe treated many years ago, has not been exposed to immune checkpoint inhibitors, this is an option. 20% of responses, an improvement on overall survival compared to chemotherapy. Erdafitinib is the only compound on pill format that we have for the treatment of metastatic urothelial carcinoma. It is a medication that is given to patients that the tumors harbor the FGFR mutations and fusions. These alterations are activating alterations and promote the growth of the tumor. So these small molecules block this, signal of proliferation. Has been compared to chemotherapy. It improves survival when you compare with chemotherapy. As compared to pembrolizumab, it does not improve overall survival, but it has a higher overall response rate. I would say that most of the oncologists that see a patient with this type of tumors, the preference is to give a targeted therapy to this patient population. And for tumab we still have few patients that they have not received that in the first-line setting, and also prove improvement on overall survival and a very nice overall response rate and control of the disease, 40% overall response rate. Sacituzumab. So sacituzumab, unfortunately, the development of sacituzumab has come with a very, very steady learning curve about the management of certain toxicities like myelosuppression and neutropenia. So this clinical trial that compared sacituzumab govitecan to chemotherapy didn't meet the endpoint of overall survival. But there has been many modifications to the way we administer sacituzumab govitecan is being developed in other settings. And when we look at the overall response rate of this agent in treating patients with metastatic bladder cancer is 30%. So it's not a negligible overall response rate. So we are awaiting and see, if in other settings, the clinical development is smoother and it regains, an indication in bladder cancer. And finally, targeting HER2 overexpressing tumors. So it has been a target that, investigators on bladder cancer has been chasing for a very, very long time. And finally, we have trastuzumab deruxtecan is a antibody drug conjugate given to patients that overexpress HER2 leads in patients that has already received 2 lines of therapy, an overall response rate of 60%, with a very prolonged median overall survival, only 41 patients treated, but got FDA accelerated approval. And I encourage everybody to, inquire if their tumors express HER2 and inquire about this treatment option. Practice changing the establishment of pembrolizumab and enfortumab, and this new antibody drug conjugate trastuzumab deruxtecan for HER2 expressing tumors 3+ on immunochemistry. This is the treatment algorithm. I'm going to say that the take-home message is that almost everybody should receive immune checkpoint inhibitors in the first-line therapy, the preferred regimen enfortumab vedotin, and then we sequence therapies, based on what the patients have received before and paying attention to biomarkers of response to targeted therapies. Always inquire about clinical trials. We are always available for questions from patients and from oncologists in the community. And, thank you very much to all of you, to the families and caregivers. And I think the best is yet to come, and Dr. Grivas hopefully will bring a lot of hope to all of us. Thank you very much.
We'll talk, Dr. Nadal. Thank you so much. You covered amazingly well the very broad topic, very busy, landscape. And I can say 15 years ago when I started my career, I would say in this disease, there was a very different landscape with most of those options not being available. Any quick question from the audience? Anything virtual, Jonathan?
It's possible to get the slides.
I think we can.
Yeah, because there was a lot of information and I took some picture, but honestly, I'm just wondering because I would like to review it at home. So thank you so much. Thank you so much. It was so interesting.
Yeah, I think we can do that, Rita, right? Is that possible? Perfect.
It will be definitely shared the slides, but the recording will definitely be available.
Fantastic. And Dr. Nadal, I'm sure you're happy to provide the slides, and I'm happy to provide my slides too. Great talks. And, it's really, to be honest with you, really amazing to see the landscape changing so quickly, so abruptly. And what I will try to do in the next 10 to 15 minutes is just to show you what is happening in the field in terms of new trials and how we can keep the momentum going, the pace going to change the practice even more, because we don't want to stay complacent. As I mentioned to you, the talk that Dr. Nadal gave is a product of clinical trial work over the last 10 years and beyond. It's amazing to see that. So why clinical trials? How we make progress is through clinical trials. Everything you heard so far by Dr. Sunkara, Dr. Nadal is coming through clinical trials. Of course, cancer is a difficult opponent. There's no doubt about it. And it's common to have resistance to treatments. And the continuous development of new drugs depends on clinical trials. So we cannot stay complacent and keep improving the life of our patients. Conventional therapy may work in some cases very well. We can cure patients, but it doesn't work for everybody. So, we have this one-size-fits-all approach. We want to be more personalized in the future and develop more therapies and to have more options for our patients. The other thing is, and I'm trying to talk close to the microphone as well so I can be listened. Clinical trials provide often early access to promising experimental investigational agents and novel treatments that may not be received as standard of care. And it's usually, and I think I would say always, there is a good rationale. The why we do a clinical trial is based on some good rationale and some early data that pretty support and back up those clinical trial designs. And of course, there are many committees, scientific committees, ethics committees that oversee those trials in detail. And I think it's important to acknowledge that. And of course, as I mentioned before, everything you saw so far comes from clinical trials. These are closely monitored. Safety and well-being of patients is of paramount importance, so in consideration. And again, our goal is to keep saving lives and providing improvements to quality of lives. And I want to very, very quickly give a shout out, to the team members who work very, very hard to make clinical trials available for patients. It takes a whole, not a village, but the whole world. Multiple people work very hard, investigators, research coordinators, people who do consents, people who work on the contracts and budgets in the regulatory agencies. And of course, we have a couple of representatives here today. I see Nikki and Christina sitting in the back. Hello to both of you working with Martha. These are three of our research nurses who actually pre-screen many of our patients for trials and sometimes may reach out to patients and say, hey, that trial might be a good fit for you. Why don't we send you a consent form to read? Prepare your questions when you see us in clinic to at least have this homework done to save some time. Of course, there are many other people working very hard. These are just two examples of colleagues. I want to give you a few concepts, examples, some sound bites of what we are doing at the University of Washington and Fred Hutch Cancer Center across the spectrum, the continuum of the therapy settings, the disease spaces, all the way from earlier stages to later stages of bladder cancer. So I will just give you again some snippets of what is happening. It's impossible to cover all the great work being done in this cancer center. We heard already this morning by our wonderful colleagues in urology team that we have clinical trials in patients with not muscle-invasive bladder cancer. You heard already from Dr. De La Calle and Dr. Wilcox van der Berg about trials in this space, and I highlighted one of them on the right lower corner for patients who have not been exposed to intravesical installations of BCG. We have the trial called Bridge that is comparing the intravesical administration of chemotherapy, gemcitabine and docetaxel inside the bladder installations with the conventional BCG. That trial is continuing accrual. I think Jonathan is going to finish accrual later this year. Perfect. And our team is doing a fantastic job accruing in that trial. And of course, there are plethora of other studies being done. Not only patients who never were exposed to BCG, but patients who had BCG, but BCG may not work for them. I always say patients never fail. The therapy may fail a patient. That's a quote we use. And for those patients, we may have clinical trials for what we call BCG exposed or BCG unresponsive non-muscle invasive bladder cancer. So these are just examples taking into account, for example, immunotherapy given through the vein, things that Dr. Sunkara and Dr. Nadal presented. How can we combine potentially those with intravesical therapies? These trials are ongoing. And of course, there are trials just with intravesical delivery of agents. We heard from Dr. Sunkara about neoadjuvant therapy, meaning before radical cystectomy and lymph node removal. And I want to focus just on a couple of examples of trials that we, as a group here at Fred Hutch and University of Washington, developed to try to meet the unmet needs that our patients have. And we have so many clinical trials going on. Rajitha, you covered so many of them. I will just focus on a couple of examples, and this may be familiar to some of you in the audience. Bladder cancer comes in the usual form of the conventional form, which is called urothelial carcinoma. The urothelium is lining up the internal part of the bladder. These are the cells living in the bladder. So if you get a transformation of those cells, you get urothelial carcinoma. What we try to also learn is how to optimally treat some variations of this cancer type. There are different, we call them variants or subtypes that we see sometimes in clinic. And if you think about the total number of patients, about a third of patients with muscle invasive bladder cancer may have some component of this variant different histology. Histology meaning how the cancer appears under the microscope. And in a small proportion, I would say less than 10% is a pure variant, meaning non-urothelial appearance after the microscope. So we developed this trial. You see the picture of one of our previous fellows, Dr. Calle. I should have put a picture of one of our junior faculty, Dr. Wright, who presented the data just a few weeks ago in a national conference. We're able to complete the first study in a single center here at Ferhat's UW, looking at those patients who had 17 patients, a small sample size, but it's just difficult to accrue in those trials because it's not that common to have these subtypes. And we were very, very encouraged. We saw a really phenomenal, what we call a response. So we look at how many patients had no cancer left behind in the bladder, and we saw almost 6 out of 10 patients, to be precise, 9 out of 17 or so patients had really no evidence of cancer left in the bladder. So we're very encouraged. We're discussing how we can expand on that. It's an early result, small number of patients, but we're trying to figure out how we can build on that and do a bigger study to confirm or what we call validate these results. Just to give you an example of what we try to do, and we're having those discussions actively. Moreover, where this trial, the previous trial that I talked about, focused on the combination of chemotherapy, the dose-dense MVAC that Dr. Sunkara mentioned, plus pembrolizumab, one of the immunotherapies that is given through the vein. So this is for patients who are fit enough to get cisplatin safely. Of course, we have many of our patients, we do not think cisplatin is a safe option. So how can we treat those patients in our clinic? We need more options, for those patients, even more for those with those subtype variant histologies. And we heard from Dr. Nadal about this drug, the sacituzumab govitecan. That's an antibody try to target the cancer cells linked to a chemotherapy. So I call it, like Rajitha, a targeted chemotherapy approach. This drug has been tested, as we heard from Dr. Nadal, in metastatic bladder cancer. We do a study in patients with localized muscle-invasive bladder cancer, MIBC, who cannot safely get cisplatin, and they have this variant histology component. That's another example, and Dr. Talukder was also a fellow here. We try to fulfill the mentoring vision as well, educate fellows and let them take the lead in those studies, working with us and try to get more answers, how to find more options for our patients. Moving along here, we already heard about the adjuvant therapy from Dr. Sunkara, and we try to build upon what we learned. So Dr. Sunkara told us that for a certain number of patients, not everybody, but a certain number of patients, immunotherapy with this drug called nivolumab, which is activating the immune system, this drug can be given through the vein once a month for up to 1 year after radical cystectomy. So the question is, number one, who needs this drug? So there are many trials looking at this question because not everybody needs it. There is risk of over-treatment and under-treatment, as you outlined. At the same time, can we build upon that? Can we take more information about the cancer and try to build, maybe different therapies to combine this immunotherapy with? So that trial that I have the opportunity to help lead is a trial that looks at it's technically a vaccine. The way they make that, when Dr. Wright and Dr. Calle and Dr. Gore and Dr. Berg do it, what we call a TURBT, a cystoscopic removal of the tumor, that tissue can be processed and evaluated, trying to understand which proteins this tumor has and how these proteins/antigens can stimulate immune system response. Can you make a vaccine based on those cancer-specific proteins/antigens that can be specific to the bladder cancers in the individualized immunotherapy fashion? So the trial is asking the question, nivolumab by itself, which again may be an option for some patients, or combined with this individualized vaccine based on the understanding of the tumor immunology and biology. Moving along, Dr. Mian did a great job talking about bladder preservation. Again, this is not for all the patients, but some patients may find it a great fit for the treatment paradigm. And what we try to do here is we try to ask the question, if we have this model of maximum removal of the bladder tumor cystoscopically with our urologist, and then we do low-dose chemotherapy with radiation, does immunotherapy add value in that treatment paradigm? Is it worth adding immunotherapy through the vein in the chemotherapy and radiation treatment or not? So that trial has run through multiple cancer centers in the country. I have also been honored to be part of this design. Many years ago, we finished the accrual of the trial about a year ago, so we're hopeful to have results in the next year or so, try to learn whether there is added value or not from adding immunotherapy given through the vein in the chemotherapy and radiation paradigm. And to close up in the next few minutes, Dr. Nadal already covered very well, the rapid development of options in the metastatic disease field. This is the concept, again, of the antibody drug conjugates. Conjugates means that these antibodies are targeting the cancer cells based on markers expressed in those cancer cells, and they are linked with a chemotherapy drug. And the goal is to try to deliver that as specific as possible to the cancer cells. Nothing is perfect in this world, neither is this a model, but we try to be as specific as possible. You may still have some side effects because the drug may be circulated in the blood, but again, the goal is to make it as specific as possible within constraints. You see here in this slide different examples of those targeted chemotherapies or antibody drug conjugates, as we mentioned. On the top left is what Dr. Nadal mentioned. This drug is specifically for patients who have this marker called HER2. We can stain the tumor cells to look if it's overexpressed. On the right side is this sacituzumab govitecan drug that I helped develop in the last 7 years. And on the left lower corner is this drug called enfortumab vedotin, looking at a different target. And we have a study try to combine the second and the third, try to see if we can deliver two of them at the same time. Is it safe and can it help target more cells? Because some cells may be sensitive to one and some cells may be sensitive to the other. So we try to combine to see if it's more effective to combine two of them. Another example is another antibody drug conjugate in the right lower corner. We call it DV, for brevity. And there are some early data showing very promising results in combining this antibody drug conjugate targeting this HER2 protein with immunotherapy. So we're having trials, trying to look at this paradigm. Can we find safe and effective combinations looking at these target chemotherapies in combination with immunotherapy? And we try to, of course, evaluate the safety of doing that, the feasibility, and also the efficacy, the effectiveness. And what you see in this slide is just an example that was presented recently that about 72% of people had response meaning meaningful reduction in the tumor size when you combine those approaches, which is in its early days, it's with this combination, but it's encouraging when we have a phase 3 trial trying to confirm or validate those results. And that trial is available. So I always say, talk to your provider, talk to us. We can see if there's a clinical trial that's a good fit for you and try to select it if it makes sense. Last slide before we wrap up. We always try to not only do clinical trials prospectively, meaning going forward in time and compare different treatments, but also going back in time and learn. And there's a quote that I always use from the recent ex-NIH director, Dr. Bertagnoli, which is learning from every patient. And what we try to do with Dr. Wright, we actually work with mentees and trainees, and one of them is in the room, Dr. Bakaludi, sitting over there, came all the way from Greece and working with Dr. Wright and myself, and we have other colleagues in the past, and they're helping us having a database so we can actually learn from our experience. How can we get some meaningful conclusions? And Dr. Gore, sitting here in front of me, is one of the masters in the field of studies like this. And we try to learn in practical questions, right? How do people with immunotherapy, ICI means immune checkpoint inhibitor, immunotherapy given through the vein. How can we learn? We collaborate with multiple cancer centers in the country, also in Europe, and we have approximately 1,500 patients or so in the database. It's anonymized, completely identified. There's no way to figure out any identifiable data or PHI. So we're trying to learn again from our experience, and I put pictures from many of our mentees and trainees working hard to answer those questions. Again, thanks for being an inspiration for us. Ask us about clinical trials. That's how we make progress. I will leave it here, and thanks for your attention. And I stayed on time miraculously. Yes. Let's keep up the pace. I'm going to be around, for the remainder of the event. Find me so we can actually discuss more about trials. And I will say it's my distinct honor and pleasure to introduce a dear friend and colleague, Dr. John Gore. Have been knowing John even before I came here 7 years ago, and has been a phenomenal leader in the field, working with our patients and our colleagues in the urology team. He's a professional in urology. He's going to talk about caregiver burden and unmet need in bladder cancer care. John?
Hi, good morning, everybody. I always love coming to this event. It's a great opportunity to see some old friends, but also connect with some patients who I've known for a long time. So thank you all for being here. I was asked to talk about caregiver burden. And this title, An Unmet Need in Bladder Cancer, reflects in many ways sort of the lack of progress we've made in figuring out how to kind of care for the carer. You know, we always think about the patient as sort of our main target of who we're trying to help, but the treatments we give for bladder cancer are burdensome treatments. And so that induces, a lot of financial burden, time burden, emotional burden, and we're just kind of starting to understand how we can help the carers. So my work in this domain goes back about a decade. We created something called the Bladder Cancer Advocacy Patient Survey Network about 10, 11 years ago. And really the goal of this was to understand what, from the patient's perspective, were important research questions. I can experience the things that I see in clinical practice in my clinic or in the operating room and see where the gaps in care are. But our patients who have the lived experience of dealing with bladder cancer have a whole wealth of expertise that we can learn from. And so a lot of the questions that came about as the highest prioritized questions in, for example, non-muscle invasive bladder cancer are actually similar to what we think are important questions as clinicians. And so you can see that the top questions were, well, gosh, how can we make better decisions when cancer comes back about who should have a radical cystectomy? And what are some of the best treatments? And I know you heard a little bit about some new trials in this area. What are some of the best treatments when BCG doesn't work? What you don't see on here is that further down on this list, we had some questions about how these treatments may differ with respect to burden on the caregiver. And so that's a really important question. This is also a big clinical gap in care. If you ask a bunch of bladder cancer experts, they'll give you all kinds of great quotes about how important this is for them and how hard this is as a kind of clinical domain for them to manage in their day-to-day bladder cancer practice. And for me, specific to this question, I think it's really critical because when we do take out the bladder in the setting of recurrent non-muscle invasive bladder cancer, from a cancer standpoint, it works very well, but this is a highly morbid operation, and it has burden not just on the patient, but also on their family and their spouse and their caregiver as well. So I want to talk a little bit about what patient-centered outcomes research is. It's this idea that, maybe the research we can do, rather than giving you sort of an average treatment, the average patient with this has this much benefit. Maybe it can help us answer, gosh, given what's unique about me, what can I expect to happen after these various treatments? How can I balance the risks and benefits of the various options based on my individual characteristics? Are there things I can do to make those outcomes that I care about more likely? And can this system around us kind of help kind of achieve all of these individual goals? And with respect to research, I have a mentor who is in Los Angeles, and so he always puts a Hollywood spin on it. And so the Hollywood spin on it is, with respect to research, most of the time we as researchers are like the B-list celebrities. We're making the outgoing calls, trying to get in front of people so we can advocate for ourselves. But occasionally, you're the Leonardo DiCaprio and you get the incoming call. And so we got the incoming call from PCORI where they prioritized our research question as something that we would consider for funding. So the first thing that we looked at was, with respect to a comparison of bladder removal surgery and treatments that allow people to keep their bladder, what outcomes are important to patients? And you can see a lot of clinical outcomes, like, does the cancer get worse to the point where people have metastatic disease? But you also see a lot of quality of life outcomes. And you see that one of the most highly ranked outcomes there is caregiver burden. How are these two different treatments going to affect the people that help me through my bladder cancer journey? And so we designed one of the best acronyms that I've been a part of. And I know I've talked about this study before from a different spin, but this is the CYSTO study design. It's the comparison of intravesical therapy and surgery as treatment options for bladder cancer. We have a cheeky follow-up to this called CYSTO Scope, which is survival, cancer outcome preferences, and economic burden. But you can see that one of our 12-month outcomes, which we considered to be a secondary outcome, was caregiver burden. And the aim that we had to cover this was our aim 3, which is not only do we want to compare these treatments from a patient perspective, from a clinical perspective, but we also want to look at how these impact the caregivers of patients. And as patient outcomes change, how does caregiver burden change? And unfortunately, in our back and forth contracting with PCORI, they made it clear that they are the Patient-Centered Outcomes Research Institute, not the Caregiver-Centered Outcomes Research Institute. So we were not able to do the work that not only did we think was really valuable, our patient partners thought was really valuable. So we decided to keep pursuing this because we felt like it was important. So we went back to this patient survey network and we said, well, gosh, we use this survey network to understand what research questions are important to patients, but maybe we can actually learn something from patients as well. So we asked explicitly about caregiver burden, and we got a pretty high response rate. There are about 1,100 patients in the patient survey network, and we got responses from over half of those. You can see that the distribution, there's an age distribution that pretty closely matches the age of bladder cancer patients. We had very few non-white individuals, which we've been trying to improve in the patient survey network, but we had a pretty even mix of patients with non-muscle invasive bladder cancer, muscle invasive bladder cancer, and metastatic disease. More than half of our patients had undergone a prior radical cystectomy. And then you can see that the time since treatment varied. We had some people that were recently treated. We had some people that were treated 3 to 5 years ago, and some people whose treatment was a bit more remote. And on these next 2 slides, what you can see are, number 1, how big of a problem are these different areas? And then on the slide after, I'm going to show you kind of what resources caregivers found most useful in trying to support the patients that they care for or are loved ones of. And you can see if you focus on green and above, things that are at least a minor problem, these bars are pretty big. And so what's most notable is if you just look at the blue bars where something is not a problem, there are very few domains like your physical well-being, your emotional well-being that are not affected by the caregivers of bladder cancer patients. So it's something that is an impactful thing, not just to the patients, but also to the carers. In terms of what resources people used, it was a bit all over the map, but the dominant bar that we saw as being a very helpful resource was the web. And I always counsel patients that, and I know our partner here is BCAN, so I'm not just saying that because they're our partner, but I always counsel them to go to the BCAN website. It's very hard to find a community when you're a bladder cancer survivor, and I know we're all in this room together, but it can be a very isolating diagnosis. And so I think that web-based community has been really helpful to a lot of our patients. Some individual factors that we found to be associated with decreased well-being among caregivers. Well, we found that emotional well-being was more impacted than physical, that those who were younger had a higher caregiver burden, and that may relate to retirement age or being, actively employed and the challenge of balancing work and being a caregiver. Higher educational attainment was associated with decreased well-being. I mean, we have some hypotheses about that, but it was a surprising finding. And then not surprisingly, it's a higher burden the worse cancer the patient has. And then obviously we found that web-based information was most helpful to our caregivers. So what can we do going forward? Well, we've been able to recover a little bit our priority on looking at caregiver burden. Dr. Wright and I are co-PIs on what's called Best Care. And the main thrust of Best Care is for us to get longer-term follow-up on that cysto study. So we just finished getting 1-year follow-up on all the patients in our cysto trial, but this grant is going to help us get 5-year follow-up on all those patients. So it's easy to say, gosh, a year after this decision, this is how life is going to be, but it will be most helpful to patients to be able to say 5 years after, this is what this is going to look like. But one of our main outcomes is AIM-3, which includes a caregiver burden outcome. So not only are we going to enroll another 220 patients, but we're going to enroll their caregivers when they say that they have one. And that's going to allow us to look at caregiver burden, but also to look at how the patient outcomes influence caregiver burden. And this is a big study. This is a study that takes place at 36 sites across the US. That AIM-3 takes place at a smaller subset of sites, about 6 sites across the US. And it's going to give us incredibly valuable information. I do have one nugget that is slightly hot off the presses. As part of our cysto study, we did a number of interviews. So even though we couldn't do directed survey work with caregivers, we did interview 25 caregivers of cysto participant patients. And one of the things we found is that even though patients stated that their caregiver was their primary source of support, and typically that was their partner or spouse, when we asked caregivers, almost universally, they did not seek out any additional support for themselves. So clearly, this is an area where we can do a better job supporting our bladder cancer patients in their survivorship. Thank you very much.
Very short. First, thank you so much. I'm a caregiver. And I have one comment. It's a very interesting talk. I just want to say about the web-based thing. One thing that we did with decision, my wife and me in the beginning, that we don't consult with Dr. Google and Professor Facebook. And we just consult with BCAN or other institutes which are important. And I think this is something that caregivers need to know. Because we're missing information, but many times, what is on the web, it's not exactly what you need in that time.
Yeah, I think it can be very challenging. I think that if you ask those of us who are primary bladder cancer clinical providers, we almost universally direct people to the BCAN website. I am always impressed by the quality of educational information they have on that website. And then where I think there's value in, for example, the Inspire platform, is that there are aspects of bladder cancer care that I can't do a great job of counseling people about because I don't have the lived experience of going through the day-to-day of these treatments or these surgeries. And that's where I think patients sharing their experiences, caregivers sharing their experiences is also really helpful. So I agree. We try to direct people towards sort of cultivated information.
One thing to do too is if you're being cared for here with us, ask us about if we have patients, because the BCAN website is great for national people and it's an awesome resource, but we have a lot of you have volunteered to be resources for patients and for families. And so we can help connect too based on stage of disease, age, gender, et cetera. So
thank you guys.
So this next topic is one that I believe in a great deal, and we've worked really hard over the past several years to be able to get dietitians who have specialty focus in oncology. And so I'm excited to ask Hannah to come up and talk to us today. She's been with us, and I'm torturing her with all the consults that I keep sending to her, but I appreciate what you do, so thank you.
Of course, thank you. Good, I can move this. Sorry, Dr. Gore, you're a little taller than I am. No, I am so grateful to be here and grateful for this job because, a lot of the doctors here really advocated and saw the space for a dietitian, actually 2 of us, to be able to help provide and educate and really support you during your journey. So that's what I'm going to focus most on today. Please ignore the date on here. Clearly, my mind has not made it into 2025 yet. But I am one of the oncology dietitians and actually board certified specifically in oncology nutrition. Today, we're going to kind of go over how nutrition plays a role and how we can use strategies and implement them both as caregivers. I love that speech. I'm a very big proponent in caregiving because we know it takes a lot of people to nourish another individual. I'm from the South, and I quite often tell people it's how we celebrate, it's how we mourn, food is more than just calories in, calories out. It's how we express love. And especially for caregivers, I hear that a lot of it's so hard to make sure they're eating well because the patient is experiencing a lot of things we're going to talk about. I'm going to talk about side effects no matter which treatment you get, common bladder irritants, some myths we have, like you said, with Dr. Google and Dr. Facebook, and then how to implement this nutrition strategies, and then some key takeaways. Did everyone get the handout at the front? Okay, if you didn't, I brought a handout to take home with you today. And so what is the role of the oncology dietitian? Most of the time when people hear the term dietitian or nutritionist, they hide their food from me, or they think I'm the food police, or going to tell them they need to lose weight. That is one of my joys of being an oncology-focused dietitian, is I can really work with individualizing and supporting versus restricting. I can work individually with treatment-related side effects. I can give you evidence-based guidance on which foods to eat, to include into your diet, and in this case with bladder, some things to avoid. I can recommend individualized oral nutrition supplements or protein drinks that can help you with healing and muscle support. Again, I can be that other voice as for caregivers. I can teach you how to make meals, how to use your time wisely and able to support others, go over common myths, and then most importantly, maintain muscle and bone mass during treatment. Why is this important? Nearly 2/3 of patients will experience some kind of nutrition burden throughout their cancer journey. I would love to see a show of hands and hear of people who've gone through treatment if you've had any side effects that were directly related to eating, drinking, food that we put in our mouths is not just, whatever we feel like eating that day. Sometimes it can really make a big impact on how we feel the rest of the day, how our energy levels are, if we're going to the bathroom 6 to 9 times at night, all these other things that we may have not thought about before. And then on a cellular level, nutrition can affect absorption. Cancer cells, they do utilize nutrition and the nutrients, micronutrients we're putting in our body differently. And then some treatments can affect our gut lining. So if we're putting in our body, are we actually absorbing it? Then with metabolic changes, whether that's surgery, treatment, or just cancer progression, it can change how we utilize them. So we may need more calories or more protein, more fats in order to maintain that muscle mass. Because with treatment and medical nutrition therapy, our whole goal is to get you through this as strong as possible, maintaining your muscle mass long-term. So 10 years down the road, we're still able to do those activities of daily living. Then bone loss, sarcopenia, some people get DEXA scans and other things, so we can really see how your bones are handling treatment. Side effects, this is pretty chaotic slide, but it just goes to show the vast majority of people will have some kind of nutrition-related side effect, no matter your treatment or combination of them. With surgery, we can have downtime recovery where we're not moving, so potential for muscle loss. It's important to increase your protein, risk in bowel changes, urinary changes, dehydration. So we can work together to find a plan for you, whether that's small, frequent meals, altering your diet to increase your protein, and then making sure we're getting enough hydration. Radiation, whenever we are radiating that area, it can cause issues in our bowels as well. So fatigue, diarrhea, gas, bloating. This may also change the diet, which we'll talk about later, of high fiber. We may have to modify that so you're not experiencing that gas or bloating, increasing your hydration, and then again, small frequent meals to make sure we can get all the nutrition and make sure you're as comfortable as possible. Some with the chemotherapy, this can range depending on your treatment, but nausea, vomiting, changes in appetite, changes in taste, as well as changes in electrolytes. So some treatments may pull electrolytes like magnesium through your body, or actually maintain that and increase high levels that we'll have to monitor, like phosphorus in some treatments. We can implement different nutrition strategies along with your medication in order to give you some relief. Bladder irritants. This is really important because although it doesn't inherently harm your bladder or cause damage, it can make it very uncomfortable to urinate. It can increase frequency, urgency, or burning. So this is some of them, the main common ones on your handout. I went a little bit more in depth, but caffeine, a big one for people. I've had a cup of coffee already this morning. And so this is not saying you can't have it, but it's learning how to drink it safely and include water so it's not getting so concentrated. Spicy and acidic foods, chili peppers, citrus fruits, tomato-based products. Again, this acid buildup in your urine can make it painful to urinate. Artificial sweeteners, this catches people by surprise because they're hidden in a lot of foods. So, diet-based, sugar-free options, and even some gums have these artificial sweeteners in them that can cause more painful urination. Alcohol, again, being from the South, it is Mardi Gras season right now. So if I was back in Louisiana, I may have gotten some booze for this one. But alcohol dehydrates you and can cause your urine to be more concentrated and more acidic. So we want to make sure we're drinking plenty of water while managing your urinary symptoms, about 64 to 80 ounces or 8 to 10 cups a day. And for those who don't like to drink just plain water, I included a fun little mocktail, if you will, on your handout that incorporates some of these low acidic fruits and non-irritating for your bladder. Common myths. This could be my whole presentation in maybe 30 to 45 minutes. Thanks to the web, we are constantly being flooded and marketed different terms or diets. The biggest one I have is sugar feeds cancer. I get this just about 9 out of 10 people because it's one of the first things you see when you Google. The short answer is we do not have research that says glucose or sugar inherently makes your cancer grow. We do know it's part of a bigger picture of a well-balanced diet and decreasing maybe some of those processed sugars. Kind of along those lines, special one cancer diet. Wouldn't that be nice if I could find the exact cancer diet and retire on a beautiful beach? But that is not the case. Not one person is alike, not one cancer is alike, so not one diet will be perfect for anyone. A new one that I see is dairy increases bladder risk cancer. We do not have any conclusive research on this, but we do know dairy is a great source of protein, calcium, vitamin D that supports muscle and bone health. So we don't want to eliminate it. Again, it's part of a well-balanced diet. Supplements, the bigger the dose, the smaller the pill, great, cures cancer, right? That's really not correct. Many vitamins, minerals, herbs, supplements, even protein powders are marketed directly towards cancer patients, which I wish could be illegal, but we do, and they're very expensive. So people mean well, you've probably had somebody in your life recommend these products to you, and they're not trying to harm you inherently, but some supplements can actually directly interact with your cancer treatment and make it less effective. It can also increase some of your side effects from your treatment. So always talk to us, your care team, your providers, about any supplements you're taking, any powders. And if you are deficient in any vitamins or nutrients, we poke and prod you, unfortunately, a lot for labs, and we will monitor that and suggest a vitamin for you. So what is the diet? This might be a little bit, more simple than what you think, but I love this image because what we do know in research is a balanced diet that is non-restrictive and implements a lot of colorful fruits and vegetables, high fiber, and good quality protein can lead to better treatment outcomes and more support as far as muscle and bone mass. So the Mediterranean diet, or My Plate, is a very visually appealing way to look at it. If you think of a general dinner plate, not a buffet plate, a dinner plate, it's very easy to look at that and divide it in half and think, okay, this is what fruits and vegetables. So leafy greens, eggplants, cauliflower, broccoli, fruits, anything you want, very easy. Divide that plate, include it. The more color, the better, because each color of a fruit and vegetable has different vitamins and minerals. And then divide in a fourth, and we want that to be a variety of protein, limiting your red meat and your processed meat, but including things like fatty fish, which omega-3s can support energy, lean chicken, tofu, beans, nuts, eggs, dairy. And then the other fourth, the dreaded word, carbs. You need them. You're going through a lot. You need energy. So including things like sweet potatoes, rice, pasta, quinoa, all of these can be a part of a very well-balanced diet. And then mixing in healthy fats, your olive oils, avocados, nuts, seeds, peanut butters, and hydration. You're going to be tired of me saying that to you. 8 to 10 cups a day, very important. And then fiber. If we're doing this half plate of fruits and vegetables for snacks, that 30 to 35 grams of fiber a day, depending treatment, if you're having gas, you may decrease that, and really help for an overall balanced diet. This is just another way to look at it, because I think we can be stuck in a cultural view, but cultures all around the world are able to implement this diet. Even if you're taking this and adding into a burrito, you're still getting the same elements, or making a large salad, making a stir fry. It's just this kind of thought process that can be helpful. The quick takeaways, there's no one diet, it's all individualized. My Plate method, or the Mediterranean diet, is a great way to start. Your nutrition goals and plans may change as you go through treatment, and that's why it's really important to meet with a dietitian so we can kind of filter that out for you. Taking in sufficient calories and protein and water and avoiding bladder irritants will provide the best nutrition benefit for you. My other tip to caregivers, and if people want to help you, let them. You can guide them on, this is what my dietitian recommends. These are the foods that irritate my bladder. But if they're offering to bring over some food that you can freeze, let them. Let it be a little bit more convenient for you. Or meal prep yourself and keep it in the freezer for those busy treatment days. And finally, us as the dietitians, we are the experts. We put a lot of time and study into really filtering out everything and honing in our craft. So feel free to reach out to us. That's why we're here, to be able to help you.
Fantastic. Okay,
Thanks. How are you doing? Fine right now.
I'm so grateful for your talk and also the handouts. I'm sure that people will find it very, very useful. Very quick question, very question.
Yeah. You want the microphone?
Sure, whatever.
Okay.
Quick question. Thank you.
When you're talking about bladder irritants like the spicy foods, is that just because it's uncomfortable, or does that exacerbate cancer conditions? Which was the reason?
Yeah, it just.
I mean, you don't need that. But...
I know, I'm loud to begin with. No, it can just exacerbate symptoms. So it's not inherently hurting your bladder, but it can just be very uncomfortable for you. And each individual, very glad you asked that, each individual may experience different symptoms or be more or less sensitive to those bladder irritants.
Daniel, do you want to ask a quick question, or you're good?
First, thank you so much, because my wife, I'm the caregiver, the Nutrition Institute of Caitlin, which is now on the leave. It's amazing the work they did. But what you said about the supplements, actually everything that my wife took or eat during the treatment was confirmed with Caitlin or with the team of Jonathan Wright or Grivas, because we knew that it might affect things and all this advice, take 15,000 milligrams of vitamin D twice a day. Thank you so much, but no, someone said it was very important what you said about it. Thank you.
Thank you so much. That's great. And appreciate it, Hannah. Again, the handouts that Hannah let us have outside, and pick it up on your way home. And without further ado, it's my great pleasure and honor to introduce the next speaker, Dr. Hannah Hunter. Dr. Hunter came to us a few years ago, Hannah, at the time, Blair's, it goes very fast, but we're so lucky to have you here. I always tell my patients, when I send them to Hannah or you, to both of you and others, that they're going to find it extremely useful and productive. And individuals like to talk. I'm Director of the Department of Rehabilitation Medicine here at UW for HATS. Hannah, thank you.
Thank you, everyone, for your time today. I talk about exercise and physical activity a lot. Today is particularly special, given that bladder cancer is something that has affected my immediate family, including my dad and father-in-law. So thank you, everyone, for being here. I get to talk about exercise, and I would say Most would agree that exercise is a healthy thing to do. What's really particularly important in cancer care is that it's dosed appropriately, and when patients are exercising, that they're actually reaping the benefits of physical activity and exercise at a frequency and an intensity that's appropriate at different stages of a patient's journey. Looking at this like graph in green and blue, that's the number of exercise articles that have been published in bladder cancer over time. As you can see, there's been a huge influx in the past few years. And part of that is up to a few decades ago, when patients were sick or going through some sort of medical illness, the doctor would prescribe, let me go to the next slide, bed rest, right? And it would be stay in bed for weeks to months until you feel better, right? And it really wasn't a quick like history aside. And it wasn't until the baby boom, post World War II, where labor and delivery units were filled with women who where units had run out of beds for postpartum women. And they realized that the women who weren't staying in bed for weeks, the ones that were moving around and leaving the hospital, were actually doing better. I suspect they had less swelling, maybe less infections. They were mobilizing quicker, they had more energy, and it really led to this interest in early mobilization and safe physical activity, even when the body is going through a major stressor. This has also led to this idea of prehab, which is something I love to talk about and do research in. This idea of improving functional fitness and capability prior to some major medical stressor, whether it's cancer treatment or surgery, with the hope that we're improving a patient's physical resilience to bounce back quicker or to be able to recover faster, knowing that we've improved muscle function in an area that might be surgerized or be affected by treatment. And so overall, while exercise is a healthy thing to do, our goal is to have a strategy to improve physical resilience for particular patients at different stages of cancer treatment. From an overall perspective, looking at this graph in, I think, blue, green, and red, we know that with normal aging, unfortunately, our bodies decrease muscle mass over time, and that starts in our 30s. And so after our 30s, our bodies unfortunately slowly decline in function if we don't add some sort of stimulus like exercise to improve physical fitness and stamina. Medical stressors or a diagnosis like cancer or surgery or systemic treatments might specifically affect body composition and body mass. So our goal with exercise is to use it as a strategy to mitigate those changes in body composition and improve that physical resilience. And with all the exercise studies that have been done over time, finally in 2022, the American Society of Clinical Oncology came up with this guideline, and I know it's going to sound groundbreaking, but the guideline was that oncology providers should recommend aerobic and resistance exercise during active treatment to mitigate side effects of cancer treatment. So it's taken some time to get to this goal, but the culmination of exercise research has led to not only the knowledge that it improves muscle health and body composition, but it can improve fatigue, improve sleep, decrease your risk of falls, improve heart health, brain health. And I would argue the most important thing, it helps you do things that you want to do. But we do need to be somewhat targeted in that. And a common phrase that's used is that exercise is medicine. And my follow-up to that almost always is that in the same way we prescribe medications with a certain dose, frequency, side effects to look out for, we should also do that with an exercise prescription. So when patients are starting to engage back into physical activity or trying to figure out a new baseline of physical activity in the setting of fatigue, we want to be pretty specific about how much exercise to do, how frequently, what to monitor for, and make sure that it's actually beneficial to patients. Our general guidelines is that cancer survivors and patients going through treatment should engage in at least 150 minutes of moderate intensity activity per week. What is moderate intensity activity? There's fancy ways to measure this, looking at heart rate or VO2 max, but we also learned that patients are very good at self-reporting their exertion. So moderate intensity exercise or physical activity is activity where you feel like your heart rate is mildly elevated, but you're able to carry a conversation. So that could be gardening, a brisk walk. If you're able to sing a song, you're in the light intensity zone, so that 1 to 3. But if you can't sing a song but able to carry a conversation on the phone or with someone that you're walking with, you're in that moderate intensity zone. And this is not to say that vigorous intensity should be avoided, but particularly when you're restarting physical activity or finding a routine, we want to stay in that moderate intensity zone. The other recommendation is to engage in resistance or strength training exercises twice a week to reap these benefits that kind of ripple into different domains related to quality of life. And this is not to say we want patients to go from no activity and jump into 150%. Our goal is to develop this prescription to slowly build up to that over time. And a key component of that is pacing. So when you talk about physical resilience, I think of exercise and nutrition being fuel in your gas tank to help you do the things that you want to do, to keep that car running smoothly or efficiently. Sometimes medical stressors like cancer treatment or cancer in itself is like asking the car to do more, like hauling a load from Home Depot or Costco. So the car is still doing what it's supposed to do, but the gas mileage may not be as efficient because it's doing more. It's fighting side effects of treatment. So that gas tank may contribute to this feeling of fatigue. Exercise and nutrition are a way to kind of fuel your body or fuel that car to do things that you want to do. And then pacing is the way that you drive that car. So if you're hauling a load from Home Depot and you're stepping on the gas every time the light turns green versus slamming on the brakes, that gas mileage is not going to be great. My husband loves to play this game where he tries to like see that number of like miles per gallon go up as high as possible. So he'll like slowly hit the brakes every time he knows a stop sign is coming. Let all the cars pass him when the car turns green to slowly to efficiently, I guess, use the gas mileage. And that's how I think of pacing when it comes to physical activity and exercise. It's a strategy that conserves energy for things that you want to do while you also reap the benefits of exercise. So when you come up with a conditioning exercise, it's something that should be manageable on a good day and a crummy day. So this is that mix of aerobic activity and resistance training. If you're able to find a baseline where you're able to do a week of physical activity and you're not seesawing between overexertion and rest, that's when you can think about increasing your physical activity time or intensity. If you do a physical activity, let's say you go for a walk and you're finding that you need 2 or 3 days to recover from that walk because you did too much, or you can't do anything else for that day, like bake a meal or run an errand, that's what we want to avoid. No seesawing and trying to find a sustainable routine before you build up over time. This kind of seesawing, like roller coaster on top of those red dots can be, worsening of fatigue or a musculoskeletal injury, which we're trying to avoid. When it comes to increasing physical activity, our recommendation is to not increase by more than 10% a week. And this is the same advice we give professional athletes or athletes who are returning after an injury, just to make sure we're pacing their recovery or return to play in a safe way. More so than just adding in exercise during your day-to-day or a week, there's also a benefit to the idea of just decreasing sedentary time. And there's emerging evidence and research on this with aging in terms of longevity. So more so than feeling like you have to dedicate 20 extra minutes of the day as a burden of exercise, if you can break up periods of time where you're sitting or laying down for 2 to 3 hours with a walk around the living room, practicing sitting to standing, there's actually benefit in that in terms of what it's doing for your muscles and overall metabolism. Sometimes it can be challenging to know how much to do or how that your body can handle when you're, let's say, having side effects where your appetite is affected and you're not eating as much. So things to look out for when it comes to incorporating exercise in your day-to-day is exercise should improve your fatigue. If you feel like your fatigue is worsening and it's taking you 2 to 3 days for your muscles to recover or your joint pain to recover, you might need to cut back. If you develop any new pain or discomfort with activity that doesn't get better with rest, that may be a time to seek some evaluation by a rehab professional or expert to help hone in on what that home exercise program may look like. And I'll end with some kind of tips or takeaways that we've learned in exercise oncology research on things that help healthy habits stick. Pairing exercise with activities that you enjoy is really helpful. So rather than it being more time spent in a day when you're feeling a little crummy, we want to pair exercise with talking to a friend or catching up with a loved one, listening to music or an audiobook. And my favorite concept is making it practical to sprinkle in some exercise snacks throughout the day. And it wouldn't be an exercise snack if we didn't do something physical in the middle of the day. So when it comes to targeted exercise in the setting of bladder cancer, we really want to focus on hips and core, particularly because when the body goes through a stressor, it's very smart and it burns big muscle groups first for fuel. So the body knows where those areas are. And so one way to do a seated exercise to activate some of the core muscles is something called a seated march. So since everyone's seated, you're going to sit up in kind of your on. Okay. I'll try to stay in frame for those on Zoom. So you're going to stay in your seated posture, squeeze your shoulder blades back and feel like your body is upright as possible. And then you're going to raise one knee up towards the ceiling and hold it there for about 3 seconds, bring it back down, and same thing on the other side. And as you do that, you should feel some of the lower abdominal muscles engage. It seems easy, but can be surprisingly challenging. If this is a little too easy and your shoulder range of motion allows, you're going to raise both arms up overhead while you do that. And the key with this is that you're going to prevent your body from swaying and try to keep your upper body as still as possible. Oh, beautiful. Do we feel some core engagement? Yeah, good. So quick ways to incorporate exercise snacks in the day is a great way to kind of break up that sedentary time, get muscles moving, even if you stay seated. It's also shown that keeping track of your physical activity, whether it's using a digital health app, a Fitbit, or a written diary is really helpful. And another tip is schedule exercise at a time of day where you have good energy. Saving it for 9 p.m. may not be the best strategy when you're feeling pretty tired to begin with. And in terms of a goal, maintaining function is also a win. Kind of going back to that graph on that first slide of just decline in muscle mass over time, even maintaining your function is a win when it comes to incorporating physical activity. I talk to a lot of patients who have goals of returning to a prior level of fitness, maybe before a cancer diagnosis, which is a great goal. But often our short-term goal is to figure out a sustainable baseline for now and move forward to make progress for their future. And if kind of coming up with a practical exercise program is a bit challenging and having some difficulty with pacing, working with an exercise expert or rehab expert can also be helpful to hone in on those specifics. So thank you.
Thank you so much, Dr. Hunter. Wonderful. And thank you for trying to engage my core as well. I need help from you. So thank you so much. Great talk. Since we're running a little bit on a Greek time, people may know that I'm from Greece. I use this joke often. We're going to encourage you to find Dr. Hunter here and she can ask questions for you. And definitely, we refer patients to the cancer rehabilitation or the physical therapy as well, a different separate mechanism all the time. And I would like to introduce our next session and the next co-speaker with me, Dave Walt. We're very, very honored to have Dave with us today. It's a special time. And I have to say very briefly that Dave, number one, he's a caregiver. He was the husband of a wonderful individual, Debbie Walt, who inspired us and keeps inspiring us to do research and move forward with identifying more treatment for our patients. Debbie was a patient of ours. Dr. Andrew Shea one of our colleagues who's a scientist, a physician here in the Ferhat UW, was attending, and of course the whole team, worked with Debbie and Dave over several years. So we asked Dave to join me for about 10-15 minutes of an informal discussion. We did the same thing at the Bladder Cancer Advocacy Network annual think tank meeting this past summer. It was a big success in terms of the information we gathered and the things we talked about. And the reason Jonathan and me asked Dave to come over is twofold. Number one, it's important to hear from the caregiver themselves. And also we want to talk a little bit about a very, I would call it special, unique program that we have here, which we call it TAN, T-A-N. What it means is a tissue acquisition necropsy. It's a long name. It's pretty much a research autopsy. And we do this because we try very hard to identify why these cancers are so aggressive, why they develop metastases that you talked about. How can we identify markers and targets for treatments that can help people behind us? And I always find it personally extremely inspiring for me, Dave, to have people like Debbie who agreed to do that with you, of course, and of many, many patients. When I look at them in the eyes and talk about this program, it always gives me so much inspiration, and because I see the meaning and the legacy that the patients want to leave behind, helping us understand this, why the cancer is aggressive, how can we find more treatments? So we can sit down and have a nice conversation. Dave, I will let you introduce yourself first. I'll give you the microphone, say a few words, and then we can talk a little bit more.
Test. Oh, okay. I'm not an eloquent speaker like most of these people are. So I'm just a regular person. Anyway, my name's Dave Wold. My wife's name was Debbie Wold. I called her the Italian for various reasons. She was, but anyway, you want to go into what it was all about?
Thank you, Dave, for joining us. And, if you want to, very briefly, just, I know it was a long journey, many years, of course, but if you can tell us just maybe in a few sentences in your experience, just a few words about the treatment journey with Debbie over the years, and how did it feel for you as a caregiver?
Sure. Well, as a caregiver, it was actually Debbie and I felt just before she passed away that it was probably the best 7 years we had together. We grew very close. Our intimacy changed. Prior to the cancer, it was one thing. After it was poop and pee talks. And that's just what you do, and we actually enjoyed the venture. It was a real trip. She passed away a year ago today. And on the 29th of February, actually, so she caught leap year. So I only have to mourn her once every 4 years, which was thankful for. Anyway, I wish Dr. Gore was still here. I haven't seen him in a long time, but we found out she had cancer up in Everett. We were sent to UW. We met with Dr. Gore on January 3rd, 2017. He determined that he could not do surgery. It was not an option for us, so he put us with Dr. Shea. Dr. Shea became our oncologist for 7 years. And our first meeting with him, we found out that she likely only had 6 to 18 months. And we left after the meeting, kind of everything spinning at that time. And we decided we were going to go down the waterfront in Seattle, and we rode the Ferris wheel. We got up to the top, and I looked at Debbie and I said, "What are we going to do?" And she said, "I don't know. What do you want to do?" And I said, "Fight." And she went, "That sounds good to me." He gave us options. He gave us a direction. Let's go that way. So we did. And that was our whole goal. We had 4 purposes. One, obviously, if it could be cured, great. If not, then use her life to help other patients in the future. And let the medical community use her life as a means of hope for the future for others. And we got that.
Thank you, Dave, for sharing that. I remember the first time I met you and Debbie, when Dr. Shea and me tried to enroll Debbie in a clinical trial that we talked today. And for different reasons, we could not do that. But the second time we met, after we discussed with Dr. Say, I introduced this idea of this research autopsy, which is always something, a very, very, special conversation with our patients. Can you tell us a little bit more how this was received by Debbie and you, what it meant for you?
It was actually, I was kind of surprised how she responded. She responded very positive. I don't think, he came in and told us all about it, went through the paperwork with us, and then he left to give us time to talk. Well, I don't think the door had shut, and she turned to me and said, remember the Ferris wheel. We're going to keep fighting. And that's what this is all about, is getting cells, cancer cells, good tissue, bad tissue, whatever they need to continue the fight. And that's what our lives were all about. And it continues here. And I'm very thankful for Beacon. I'm very thankful for the opportunity to come and see people like you, and especially to meet a guy like this and Dr. Shea, huge blessings in our lives. But our whole goal came right down to that. So when he walked out the door, it wasn't 10 seconds and we both went, yeah. And it's just, I can't encourage patients and caregivers more to help these folks out with their battle against what we're facing.
Thank you, Dave. It's always very emotional time, when we have these discussions. And, it's, as you said, it's so important to understand the why. And our goal in life, with all we do is to try to save people and prolong their lives meaningfully and help the quality of lives. And cancer is a tough opponent. And sometimes we cure people, sometimes we don't, but we want to increase our chances. And the mechanism we use is to try to understand the different areas of disease and the different areas of metastasis, because we cannot practically do biopsies in all those areas when someone is alive. How was if I may ask you, Dave, how was the actual, when the time came and Debbie left us? How was that part of the process? It was smooth in terms of the activation of that paging system that we have in place and the ambulance and all these logistics.
That was interesting too. She passed away at 11:52 at night, so just before midnight. And I called, the agreement we signed with hospice was that they would be the ones to call UW and get her moved down. I didn't hear anything for about an hour, so I called the number I was given on the forms, and they hadn't been contacted yet. So within an hour and a half, all the way up to Arlington, they were there and they picked her up. I got to say, the handling of Debbie, her body, was amazing. The care and love, it was perfect. I was 42 years in the criminal justice system. I saw autopsies. I saw pictures of autopsies. I saw how people could be treated, their bodies could be treated. And this was so comforting. That's the only concern she had, was how will I be taken care of? And I basically told her the same way they treated you the last 7 years, with a great deal of care and love. And it was true. I mean, it just couldn't be better. It was fast. It was easy. The care for me was amazing, because the only call I had to make was to the mortuary and say they got the body. Everything after that was done. I didn't have to worry about anything else. And my baby was cared for.
Thank you, Dave, for sharing this. And I'm so, glad to hear that Debbie and you felt that this was the right thing to do, and the whole process went smoothly. And of course, after the biopsy took place, the body came back to you as you wanted. It did not interfere with any other process that you had in mind with Debbie.
It was absolutely perfect. I had kind of forgotten about the whole process, and I think it was about a week and a half later, the mortuary called and said that, she was done. She was ready for the memorial service. And just like I say, the comfort I received from all of it was just amazing. And just the thought that she's still fighting with her body. I mean, it's just crazy good. And I'm excited about that, because it gives me a chance to come here too, as my part as a caregiver, to say, hey, this is what's going on. Don't be afraid of it. Please use it. It's a great opportunity to serve.
Thank you, David. I can share with you, we had a couple of occasions that actually a couple of patients passed at New Year's Eve. And I remember vividly that this indeed took place. People go together, the ambulance came, people go, there's a paging system that actually brings people together, pathologists, people who do the biopsy, surgeons, urologists, and this happened day or night, which is just, it's amazing that this capability exists.
And it was comforting to me to know that she was going to be taken care of. And I mean, I was up all night. My brother and my sister-in-law were there with me, as was my daughter. And I mean, we actually went to breakfast that night because we knew we didn't have to worry about anything anymore. It was being taken care of for us, and just the peace and comfort that came through that. And throughout her travels with the cancer, exercise, right diet, amazing stuff. I just have loved what I'm hearing here today, because it's everything we did. Yeah, but on top of that, and what helped us also get through the cancer and the autopsy, walking through that little 4-hour trip, 5-hour trip, what it was our faith in Christ. Faith is just as big a deal here in fighting cancer as anything else, and it helped me through that night. It really did, along with the comfort that I received from you guys. And people like this, how can you lose, huh?
Thank you, David. You're very kind. You inspire, you and David inspire us every day. And like Dr. Say, he couldn't be here today to do what I'm doing here. I'm filling in for Dr. Say. He's a wonderful physician, scientist, and a human being. We're blessed to work with him. And I tried my best to at least fill his big shoes. And I'm so honored to do that with you, Dave. Any questions from the attendees today? Anything you want to ask Dave or me about?
I really appreciate your story and thank you for sharing.
I'm glad to.
Thank you. Can you just tell us a little bit about what's come out of this?
That's a great point. And, you know, we think about this as the way, as I mentioned before, to understand the different features that the cancer has that make it aggressive, make it metastasize or spread to other organs, and why it's resistant to some treatments or not. And what Jonathan is asking is very important because what is happening afterwards? What the legacy that they gave us. So the team is being assembled midnight, you know, no matter what time of the night or day is. We do these different biopsies, pretty much, of different acquisition of tissue from different origins, and we try to create models of cancer in the laboratory. We try to create cell lines, and we try to implant these tumors into models. We call them patient-derived xenografts. It's a long word and saying we try to create models of this cancer in the lab, or what we call 3D organoids, that we try to recapitulate, you know, what is happening in the patient in a laboratory model. And of course, this is handled with, you know, great care, and it's approved by different committees. And we try to test different drugs, understand what mutations, DNA code changes this cancer has, and try to correlate those changes in the cancer tissue. But also we collect blood and see if there's a cancer set DNA that may be floating in the blood. And we see, can we understand this biology of cancer from both the cancer tissue and the lab? And then we go back and we look at the medical record. It's part of the consent, and we say, okay, this patient received that treatment, did well for a while, but that did not respond. Can we learn something from mechanisms of resistance to treatment using those models in the labs in terms of understanding the why this treatment worked, why this treatment did not work? How can we find about the resistance mechanism? How can we identify using that models new targets for more therapies down the road?
Yeah, so this has grown to be the biggest autopsy program for bladder cancer in the world. The first bladder cancer models from metastatic spread tumors have come out of this program. We're looking at the heterogeneity that Sunkara talked about, the difference between the bladder here and the metastatic spread here or here. What makes them go different places? Are they the same? Can we affect treatment based on that? It's been, I mean, I got tingles. It's been an absolutely incredible gift that you, your wife, and others have done. And I just can't thank you enough for sharing today and sharing before. So. All right, we got one more session to go through. Another one on under the research umbrella. And my thought with this today was to just kind of help everybody understand a little bit about how great our jobs are, really, and the fact that we can sit around, ask questions, and then find people who can help us answer those questions. So again, I'm Jonathan Wright. I'm the urologist here. Scott Kennedy.
Scott Kennedy. I'm associate professor in UW in the Department of Laboratory Medicine and Pathology.
And I'm Michael Hafner. I'm a pathologist at the University of Washington and Fred Hutchinson Cancer Center.
So I'm sitting there in clinic, and one of the challenges, again, we go back to the beginning of the day, people with early stage bladder cancer. We heard a lot about recurrences, a lot about the intensity of the surveillance, how can you do these cystoscopies. And I think, how can we detect these tumors even sooner? How can we potentially not have to put them through cystoscopies? How can we monitor during the treatments that they're getting? Is there a way that we can do this? Well, we're talking about really small amounts of tumor in these individuals at these times. And so I was talking about this with a colleague, and he said, well, you know what? You got to talk to Dr. Kennedy. He's got this really cool technique that he's developed for finding small little things. Tell us about it.
Yeah, so this was a funny story because my colleague is literally right across the hall from me, and ran into him in the hallway, and he's like, you got to talk to Jonathan Wright. So, so the idea is, you know, I'm sure there's a number of people in the audience that they've had their tumor sequenced or they've had their blood sequenced for mutations or driver mutations of cancer. And those platforms have an error rate, and so if the level of that tumor mutation is below a certain level, you can't confidently detect them. And so my research program is focused on using technology development to lower those error background to very low levels, so we can see these low frequency mutations. And what that means is that you can see those mutations earlier, or if there's minimal residual disease, which is kind of a big thing in cancer detection right now, can we detect that even lower? And the idea is actually really simple. It's a mutation by definition is found on two strands of a double-stranded piece of DNA. And we just sequence both strands and compare them together. And like things like sequencer errors only are found in one strand and not both. And so by that we can actually detect mutations. I mean, you're talking 1 in a million as opposed to 1%, right? It's a huge difference. And so it's a pretty big hammer. And I've looked for a lot of nails, and this one just happened to be a really interesting nail. So that's how this got started.
So patients are coming in, many of you have donated urine, and we collected urine from you. So one of the nice things from a research perspective is that when you have your bladder intact and we're worrying about a bladder cancer, those tumor cells are shed right into the urine and we urinate them out. So it gives us a great opportunity to collect and then monitor for response or to identify recurrences. So we set up a biorepository, patients come in for follow-up, and we're collecting these at multiple time points. And then we got together and tell us a little bit about kind of what we're seeing so far.
Yeah, so the general kind of setup of the study is, people donate urines before they go in for treatment. This is for currently non-muscle invasive bladder cancer, so before BCG therapy, and then at the conclusion of their therapy, and we purify the DNA from the urine at both time points, and then we ask, do we see the tumor mutation at those time points, and then also do follow up to a year out, and ask the question, does the amount of tumor mutation that's found in the urine correlate with the timeline or the time at which relapse occurs or if it occurs? And surprisingly, we actually found that seeing a mutation, even at a very low level, prior to any treatment, so this is like post-resection of the tumor, but before you go through any sort of treatment, is actually the most predictive of relapse. And that's without any sort of monitoring, like cystoscopy or anything like that. That hasn't happened yet. So that suggests that it may not be necessary or to do cystoscopy monitoring, and we could predict ahead of time the chances of you relapsing within about a year. And so we've put in a grant, which Jonathan may talk about, but in hopes of expanding that. This was an initial cohort of 30 people, and we want to expand this to several hundred and see if these, how accurate those predictions are.
Is that, and we're waiting to see if the grant gets reviewed with the current situation going on with the holds on NIH right now. But this is where everybody here can be so helpful for this, donating samples, for example. But also these first 30, we don't have any money to do that. You can't go to the NIH and say, hey, we have an idea we want to do. Well, they say, give us some data. This doesn't make us fund it. So you need data to get a big grant funded, but you need money to get the first data. And so actually, it's these first things that we've done have been from people. They all pull together, and we use these to be able to do these types of very preliminary studies to say, yeah, we see a signal. And now we put in, now a couple years later, a multi-million-dollar grant to try to do this on a much, much, much larger scale. And not just in non-muscle invasive, we're also putting in for muscle invasive bladder tumors as well, and also those that have upper tract tumors. Tumors are in the renal pelvis, down to the ureter, and those that have things called Lynch syndrome too. So just give us a brief topic on what you might be seeing in that setting.
Yeah, so in muscle invasive, the question is, can we kind of get an idea on how treatment is progressing during the I guess it's a 12-week treatment regimen, and and does that predict what they call complete pathologic response? So after you go through the treatment and you get the cystoscopy or cystectomy, the pathologist looks at it and they can degrade on how much remaining tumor is there, and sometimes about 30% of the time it doesn't look like there's apparent tumor there. And so the question is, can we take urine and ask, can we predict that subset of patients that have a complete response, and maybe down the line, those people that have a complete response, they don't have to go in for bladder removal. And then and our preliminary data suggests that we can at least predict to some degree that roughly 30% of patients. And then the second part is Lynch syndrome, which is an inherited cancer predisposition syndrome. And there's a particular DNA mutation phenotype or signal. It's called hypermutation. And people that have Lynch syndrome, their tumors get, huge numbers of mutations. And we can actually detect that phenotype in the DNA, and only the tumors that those individuals get that hypermutator phenotype, not the actual just like normal tissue. And so we can actually count and see this elevation of level. And the hope is that we can use that as a monitoring method for people that have this predisposition syndrome, that they don't have to because currently there is no monitoring method for it. It's just symptomatic.
I think it's really showing how, we can take these concepts, start applying them, and you can see what the end goal is, put me out of business, basically. I can't do cystoscopies and I can't do cystectomies, but it's the other thing that I see too, we heard a lot of talks today from our various treatments for early and for later stage, and we keep seeing these percent that respond, and we just give them this treatment. We just give it, and then a few months later do a scan or do a cystoscopy or something. So could this test be used to monitor during treatment to see if you're responding or not? Are we seeing the numbers go down? Are we seeing these mutations go down to suggest yes, stay the course? So I think the potential is really exciting. I really enjoyed working with you on it, and it's been a lot of fun. So on the other side, we live in Seattle, a lot of technology here as well too. And I was at a talk, and again, we go to a lot of these lectures. We have lectures every week, and not always are they things that are necessarily you're interested in, but this was a talk on prostate cancer, and Dr. Hafner was giving this talk on prostate cancer. And the talk happened to be about machine learning, artificial intelligence in cancer with biopsy slides. So just tell us a little bit about kind of the general concept of this.
Sure, yeah, so I'm a pathologist, so what I do is I look at small tissue pieces that are procured as part of a biopsy. And we take these small tissue pieces, slice them even thinner, and then put them under the microscope. And what we do in pathology is really then evaluate how do these cells look like under the microscope. Are they invasive? What is their shape and their size? And over the past, say, 100 years, pathologists have gotten pretty good in identifying what's a cancer and also being able to grade cancers to some extent. And that provides, of course, a whole lot of information for our colleagues in urology and medical oncology. But we were always convinced that there's probably a whole lot more information in these patterns that we can see. And maybe the human brain is just not capable of integrating all of these different features together. So in the last couple of years, and you've probably witnessed this, there's this massive development in deep learning tools and AI. Many of you have probably played around with ChatGPT and were absolutely impressed by what large language models can do. But in a similar way, we can now use the same type of bioinformatics infrastructures to extract features, image features from biopsy specimens. And this allows us to take now a very, very systematic and close look at all of these different elements of how the tumor cells look like. And what's been very interesting for us and for the entire field is that there are features in there that can predict not just whether cancer is there or not, but also predict the clinical behavior of the cancer. And this is sort of where our conversation started, to think a little bit more whether we can use these biopsies that are already existing from every patient and then use these deep learning AI models to understand whether there are certain features that allow us to select patients for particular types of therapies.
And so we're having this discussion, and you know, well, what is the problem that I'm facing or we're facing clinically for that we need more information on? Well, we give patients neoadjuvant chemotherapy before removal of the bladder. 32 to 42% are complete responders. There's a lot of patients that aren't complete responders. And there are some patients at the other extreme that the cancer progresses during that. And so this is monitoring during it, finding it after, finding, you know, low levels, who has leftover cancer. But this is the idea of, and I said to him, could we predict who is going to respond to the chemotherapy so we do a better job of picking the right people for it and steering people to straight to surgery, for example, who aren't going to be big responders. That's where we started. So.
Yeah, so for us, this was a great opportunity because it's a very well-defined clinical question where we know that whatever we find could have a huge impact for many patients. So we wanted to immediately collaborate, and I can remember vividly these early discussions that we had. So what we were able to do is, again, with some seed funding from philanthropy, get together first a very small cohort, about 50 patients or so, and start training one of these AI algorithms based on the outcomes that we had and correlate that with these image features. And even in the first 50 patients, we were pretty struck that we were able to achieve a pretty high accuracy of just by looking at these simple images, predict who's going to respond to chemotherapy and who's not going to respond. And then, of course, with more support from the entire group, we were able to increase the number of samples to 200 and more. And now this model is starting to be very, very robust. All of these model trainings you've probably heard of are very much dependent on how many samples you can actually analyze. And in order to be really strong and have the most reproducible model, we started to now set up international collaborations. And now from multiple different sites all over the United States and also from Canada, we are receiving samples to train our model and validate our model. And this, again, is the big advantage of this type of technology. It's very much scalable because it doesn't require a whole lot of additional tests. These biopsy slides, they're already available in any pathology department. So we can now go ask our colleagues to send us images or send us the slides. We digitize them, we run our model, and then we can hopefully in the future have a very, very robust risk prediction model that we can implement in our clinical care.
Yeah, it's really been fun. And again, taking this to a whole greater level, people across the country sharing us their information. So for me, what I could see in the future is someone comes with muscle invasive bladder cancer. We apply the deep learning to it to see, okay, yes, you should be receiving neoadjuvant chemotherapy, and then we monitor during the therapy the small tumor detection in the urine, and then we get done and we say, okay, imaging shows nothing. We don't see anything in the blood. We don't see anything in the urine. Maybe this is that person that we can say, hey, let's just monitor. And we're doing the same thing with radiation oncology too. So it's serendipity. It's fun. It's exciting, and you're getting to hear a little bit about how we try to take this field forward from from people talk about it from the bench to the bedside, but it's also bedside to bench and then back to the bedside. So. I appreciate your partnership, both of you. It's been a lot of fun, and it's going to be great moving forward. So,
Yeah, it's been a blast for sure.
yeah, yeah. And again, samples you're giving, volunteering to it, participating, it's a team effort, team science. So, any questions for us or anything else for that matter? Yes.
Testing of urine. How do you decide what genes to use? Genes that are thought to be drivers usually of cancer?
The question is, what genes does he use in the urine to detect?
That's exactly right. We basically designed a panel that covers approximately 90% of tumors. I forget the exact number of genes. It's less than a dozen, and that seems to cover the majority of them.
Present or what drove the new tumor? Or is that even
So you need to be in our research team. These are all the questions that we're asking. The question was, if we see it later, can we confirm that was the one causing it? And this is again a money problem too. So we picked this 10 panel because it covered broadly most bladder cancer genes mutations that we could pick up. In an ideal situation, we would say, let's look at your specific tumor, test it, and then apply those. That's a much bigger ask, financially and time-wise too. So part of our grant going in is to test that hypothesis. Are we doing sufficiently enough just using these 10, or do we need to do a tumor-informed panel moving forward? That would be slower because you got to send off the panel, send it off, get it tested, might have a month turnaround to get that, then devise the probes that can go ahead and detect it. So if we can do it with just a tumor agnostic, here are the 10 most common ones, that has a lot of advantage. So, and then we've been having these discussions too. We want to go back and sample the exact tumors that we've done to show this. And the other problem with his technology is it's so good that as we age, we have these mutations that happen in our body anyway. And some of these, we're just picking up normal alterations in the bladder, that are just happening. Maybe they're 5-year precursors to cancer. We don't know. But it's a problem almost that the test can be too good sometimes too.
Yeah. Great question, though.
Yes, thank you. To Dr. Hafner's comment on collecting samples from all over the U.S. and Canada, cancer is a lot broader than the U.S. and Canada. I believe the Hutch still has a partner in Uganda, for example. Is there any ability or plan, or is it actually happening that we're collecting samples from outside our home country?
Yeah, right. I think there's definitely a lot of ability, and this is the point that I wanted to really emphasize, is this type of analysis is very much scalable. And since for most cancer patients, these pathology slides are available, sharing is relatively easy. And of course, we want to start in a stepwise approach. We first built a model here with samples from the University of Washington. Now we are international, including Canada. But of course, the ideal goal would be to have a worldwide approach. And this has been done, to be quite honest. So we would not be the first one to think about this. There's been, in the prostate field, for instance, for a similar question of grading prostate cancer, a worldwide challenge called the PANDA Challenge, where people all over the world had the same set of samples available, and they developed new models to predict outcome for prostate cancer patients. So this is, I think, the great opportunity that we're seeing ourselves in right now, that the world is more and more connected, and I hope it will stay this way. And we can share things very, very easily, help each other out, and really support the individual research missions in different places in the world. The other thing that you bring up, maybe with this connection to Uganda, is another very important aspect of what we call digital pathology, where you don't necessarily have to have the actual tissue slide anymore, but we can just take a scanner, digitize the slide, and then just share it with colleagues all over the world. And this allows us to consult on cases from faraway countries where otherwise shipping material would not be feasible. So again, the technology at hand right now really allows us in that field of pathology to grow much, much closer together and collaborate.
I have a broader question. Maybe it's a closing question, but we have to leave soon for an appointment, so I'll do it now. This is a question about boundaries. We're in Kaiser seeing a urologist for very early on, and we had a thought about including an oncologist and got some pushback from that saying, well, actually it should stay in the urology silo and not see an oncologist. But I'm wondering that everything I'm hearing is about interdisciplinary and much comments about that.
First, Kaiser is a great place, and one of our former colleagues is the head urologic oncologist there as well too. So I very much trust their care. The multidisciplinary stuff is primarily in those with muscle invasive space. The earlier stage disease is almost exclusively managed by urology. We do start to, in some of at times, engage medical oncology, but in your if your situation is an earlier stage, you're going to be staying with urology at this point for sure.
Okay, so. Super helpful. Thank you.
Please give us feedback on what you want to hear for the future. And we made it almost all the way through without one technology glitch. So right there. So several of us will hang around. Thank you again. Best of luck to everybody.
Scott. I think we met once at the retreat last year. Yeah. Great, sure. Yeah. Yes.